Good morning everyone. Magandang umaga po sa inyo and welcome to this morning session on the unified algorithms on COVID-19. This is on a joint collaboration between PCP, PISMID, and HPAAC. And as you will see later, this is actually a collaboration between a number of medical society or organizations. So you'll be hearing from representatives from different societies like a Philippine Society of Public Health Physicians, Philippine College of Emergency Medicine, Philippine College of Occupational Medicine, Philippine Society of Microbiology and Infectious Diseases, of course, Philippine College of Physicians, and the Philippine Society of Hospice and Palliative Care. So I'd like to start by calling our first speaker, Dr. Lei Alfonso from the Philippine Society of Public Health Physicians.
Magandang umaga po. Thank you very much for this opportunity to share with you. I'm very honored to provide a background of HPAAC on behalf of the team, and we hope that this background will also help place kung saang konteksto po nanggaling yung ating mga unified algorithms. I would like to ask Dr. Tony to help me with the slides.
May, I don't have your slides. Yours is the only one I don't have.
Okay, sir.
Can you share it your own?
Okay, I will be the one to share it na lang po.
Yeah, yours.
Yeah. All right. Teka lang po. May I ask permission to share screen? Okay. Thank you. There you go. Okay. I hope you're seeing my screen now.
Yes, we are now.
All right, thank you. Transferring to slideshow. Okay, again, good morning po. I'll be sharing on behalf of the group. In a way, this is the context by which the algorithms have come about. And so the objectives is to discuss HPAAC, its contributions to the COVID-19 response, and its way forward in the coming days as we all respond to the COVID-19 pandemic. So the beginnings of HPAAC started out really with the different medical societies coming together with the need to provide guidance because there's a lot of evidence. And the initial ones were hosted also by PISMID, and there was guidelines for hospital care. And at that time, the Public Health Society and the practitioners were also coming up with primary care guidelines. And then providentially, nagtagpo, and we decided to work together. And at the primary care, we wanted to frame the guidelines from the perspective of the local health systems where there may or may not be resources. And we also want to incorporate their guidance from the BHERTs and community isolation units to complement the hospital guidance. And this was not just any simple task because we had to do a lot of collaboration between the different stakeholders, especially for the practitioners in the communities and the different levels of the health system. And from there on, nakita po namin maganda yung pag-work together, no? And then biglang yun pa, no, nagkaroon naman ng need when there was return to work, then we were joined by the different medical societies, the PCOM, and then the PMA also, and the PAFP. And then as we were doing them, there was this eye-opener that we needed to work together. There needs to be an intersection of disciplines and perspectives, involvement not just of doctors, but other healthcare professionals. And eventually also, we needed to involve other sectors as we make recommendations for health. For example, engineers, economists, etc., etc. So COVID-19 highlights that we really need to work together. And then come August, then we were seeing a surge and we called for a timeout. This is what HPAAC may be known for, but since the timeout, HPAAC has not stopped working. And what did we do? So when we called out for a timeout, there was this groundswell, and overnight, support started to come pouring in, and then people started to listen, and then people started to help out, and then everything just rolled and everything just kept going. So here po, when we did a problem tree analysis of this, the top part, the overburdened healthcare system, this one, it was actually also born out of the discussions within HPAAC, and it's one way of framing that what we are feeling, overburdened healthcare system, what does it really mean? Where does it come from? And below are the proposed solutions that have been also discussed with the DOH. But then if we look at the overburdened healthcare system from a medical professional's point of view, what we wanted to do is we wanted to decongest the hospitals. We wanted to reframe that hospitals are the last line of defense, and individuals, communities are really at the front lines. And what really thrilled us from the public health side is that there is a mainstreaming of the word health system, and there is now a convergence of clinical practice and population health. But very quickly, I'll step back and look at what is really here, the convergence that we saw. There is that convergence of medicine, which is the individual practice to individual patients, and public health. So the convergence, and we see what public health really means. It's preventing disease, prolonging life, and also efficiency. It is about organizing community efforts. It's about educating the individual at the individual level and at the community level, population level. And it's about developing social machinery. So how do we converge all of these things? And if we look at now, these are different service delivery platforms, and you may find yourself in one of these platforms. For example, here in the hospital, many of you might be working on a tertiary hospital, but if you want to unburden the hospital, how do we say push back, push down the patients to the community level? And making this work is not as simple as it seems. The platforms that I've shown you earlier are just part of the service delivery. And we look at the health system, it's really beyond just delivering service for the hospital or even for the individual clinics. And this is what HPAAC also wanted to help out with. So if we look at health system per se, when we talk of the health system, and we say that it is not existing in a vacuum, but in the context. For example, in the Philippines, we have our values and principles, and we have the politics, and we have the socioeconomic factors and different perspectives from the people, but we want to deliver certain services for COVID, for example, and these services should be able to reach the people at the time of their need, and we shouldn't be overwhelmed. And when we do this, it doesn't come out of a vacuum, but they're organized by inputs or resources. And this may be infrastructure, supplies, for example, PPE, human resources. That's at the heart, really. It's really it's the healthcare community, knowledge and information, and finances. All of these things should be organized to be able to deliver service that's acceptable to the people, and they don't come out of a vacuum. They need to be stewarded. Kailangan po siyang timplahin ng ating leadership and governance, and the policies come in here. And this is where much of the fighting or much of the discussion, really, much of the push and pull comes in. Because only by magandang pagtimpla po can we come out with really good service that would deliver outcomes and the goals, for example, in controlling the pandemic. Now, why did I have to discuss this, no? Because at the end of the day po, ito yung ginagalawan natin sa HPAC, and uh, everything was very new, and there were really no existing policies, even guidelines for how to deal with the pandemic at the very beginning. And so we need to realize also, we need to see that even though that that perspective showed the national level, many of us are caught unaware also of how the local health system works. And if we want to push down from the hospital to the community level, then we must be familiar with how the health system of the Philippines work. So in that sense, here you have the provincial office and the local health unit and the health center, all of which are governed by the different agencies, like the governor and the local chief executive. So it's not like when DOH says this, then the local health system does it. But when we say the local health unit, we have the municipal health officer that's guiding different midwives who are also supervising different health centers at the community level, and hopefully there are BHERs there who are also involved. Why do we need to discuss this? Because at the end of the day, the service delivery at the local health unit is presuming that you have resources, skills, and time, and that you have this surge of work that has not been there before, and that means a displacement of non-COVID services. And dito po tayo na short before, no? And we are not able to really push down because at the start it's difficult, no, to deal with this. And at the end of the day, we need to be able to deal with communities and household, reach them at the individual level also. The question now is, as a medical community, how do we work together? Because here you see, this was the initial core that I've shown you at the public health level. How do we interface people who are private practitioners, other providers? How do we collaborate together? Because this is the only way for us to be able to reach now at the individual level, at the community level, and push back our patients. How, when we talk of health services and we talk of HPAC, what HPAC has been trying to do since August nonstop was to also go beyond from the guidance at the sick level to at-risk population to the well population. And HPAC now wants or has been acting as a catalyst for system strengthening, being able to really make that system work together, and being able to provide guidance and evidence and counter checks. So the first thing that HPAC has done is to rally for the healthcare community as a strong and united voice. And this is only possible through the diverse expertise, reputation, and the social capital of member organizations and volunteers. Kayo po yon, tayo po ito, mga volunteers po na talagang selflessly have committed to make this work. And we were listened to because of these efforts together. Hindi po isa lang yung bida, but it was really a collective effort. And what we do to catalyze system strengthening? We targeted health in all policies, meaning to say the public policies po impact on population health and vice versa. If we really want to have sustained recovery, we must put our agenda in health across all the sectors. Hindi pwedeng economics lang. And we needed to fight infodemic through various audiences. And so detailing these, how does public policy work? There are various voices across the environment. And HPAC, what has HPAC done? Through your voices, we were able to amplify the voice of public health, the voice of reason. And against all odds, we were still there and we were listened to because of that unity and solidarity. And when we talk of HPAC, we brokered meetings to amplify the voice, push for evidence-based policies, interventions, or debunk them, depende po on the need. And we have been working nonstop with different stakeholders, as mentioned, as listed below. And meron pa pong iba na hindi pa nakalista. And when we talk of infodemic, how big is the problem? And we see there's a lot of information coming out regarding COVID. And tayo na nga po, bilang doktor, it's very hard for us to digest, to keep up with what is the evidence, and we might not have the time to process the evidence and curate the evidence. And this is where HPAC has come in. So mabilis po kumalat yung fake news, no? And what HPAC has done is to address the different target audiences, scientists, clinicians, general public, and the policymakers by the following interventions: the rapid reviews, unified algorithms, and the different campaigns and advocacy. So here, how we were able to contribute to the fighting of the infodemic. So thank you again to PISMID for hosting these. And these again are voluntary efforts by epidemiologists and the Asia Pacific Center for Evidence-Based Healthcare. And of course, the unified algorithms with its different versions and being updated. So evidence-based medicine at the individual level, no, and even as it is applied to the population level, it's not just about generating, understanding the evidence, but it's about fighting for science, truth, and equity. And that's what HPAC also stands for. And in addressing the public, we have our Facebook page, and you might have received the text last Friday, and that has generated a lot of attention, and it is good attention because now we are able to put in place or promote our campaign for Apat Dapat, wherein we are providing families, household empowerment, making informed decision on how they would take out or how they would be able to address their risks. So, HPAC. So ito po, ano po yung mga problemang natakil ng HPAC? To summarize, yung healthcare provider network po, yung overburdened health system, nakausap po natin ang mga ahensyang ito, no, to provide inputs on the referral network and the one hospital command. And then the health technology assessment, we were able to talk with these agencies and to support it through policy, no, and also in practice. Workplace safety, we were able to discuss with DOLE, we were able to facilitate stakeholder meeting and alignment with the DOH. And then transport safety, we were able to discuss with the following, provide inputs to the following agencies at the national level. All of these po at the national level. Communication technology, we work with DICT, social support, we have all met, no, we have not stopped working since August. So, into po, as I'm winding down, HPAC's strength is the diversity, solidarity is our fuel, and our membership fee is the willingness to fight for science and truth and equity. To sum it all, we are informal coalition, informal po, no? And we are a scrappy organization. Wala po tayong legal entity. We do not intend to come up with a permanent structure. We don't have titles. We do not have funds. Actually, wala po kaming presidente, no? And kami po ay mga, we stand up kung sino ang pwede, no? Kung sino ang available. Our strength lies in our solidarity and our diversity. And how do we work? We look, we listen, we feel, and we speak only when there is something to say, when we act, and we act when something is wrong. But until when? Ito po, hindi pa natin masagot kung until when. But many of us, we have committed that for as long as we are needed, we will continue to work on behalf of the healthcare community and on behalf of the Filipino people. So again, we would like to thank PISMID and PCP because your role was key in actually making this social movement of healthcare providers, healthcare community possible. Thank you very much, PISMID, for lending your credibility, for being there po at the very beginning in making all of these things possible. So we hope we can continue working with all of you. And thank you very much po. And I would like to turn over again the floor to Dr. Biruar.
Thank you very much, Lei. Thank you for explaining the role of HPAC in coming out with the unified algorithm. So as what Lei has explained, HPAC is an alliance, no, of different organizations that have come together and are working together. So it's not only the timeout that HPAC really wanted to achieve, but it is continuing support to the society in terms of battling COVID-19. The next speaker that we're going to have is one of the fathers of evidence-based medicine in the Philippines. He is Dr. Tony Dance. He's going to be talking to us about how the algorithms have been constructed, how to interpret it, and who are we to thank for them being done. So, Dr. Tony Dance, you may take the floor.
Thank you, Ding Dong, and thank you, Lei, for that great explanation of the history of HPAC. I think I understand it more now after listening to your talk. And thank you for pointing out the big role that PISMID played in this. No, without their leadership and the leadership of your president, Dr. Isa Alejandria, HPAC would not have happened. So without the support and the leadership of PISMID. So and one of the key roles, I guess, that HPAC has played since August was to support the development of the unified algorithms, which I think were first published in April or May. You know? So this is now even hosted in the PISMID website. If you see up there, no, sorry, it's in pismid.org. So this is the unified algorithm. So let me start by explaining what algorithms are. No? Algorithms are step-by-step procedures for solving a problem that contains logical if and then statements. No? So make decisions to be made. The origin in clinical settings is to provide instructions, step-by-step instructions, which tell users not only which tasks to perform, but in addition, the sequence by which they are performed. No? So keywords here, it solves a problem, and they are actually instructions. And there were many algorithms coming out. No? These are algorithms on classifying PUI, PUM, and cases early. And they can get quite confusing. You know, there was this infodemic of algorithms in April, and March and April, and they were really very difficult, no, to digest. And that's one of the reasons why we went in and tried to develop a system which would make it easier for the users to understand. No? Sometimes algorithms are supposed to explain and make things clearer, but sometimes they make things cloudier. So this was housed in the PISMID website, and I'm going to try and walk you through. No? So we have a lot of algorithms on patient navigation. So the first contact, primary care, hospital care, and then we have special considerations like advanced care planning. Scrolling down, you'll see in the menus, patient reintegration, personal protective equipment, and emergency medical services. We'll give you sample algorithms of that today. But I'd like to walk you through the symbols, the standard symbols that we use. Okay. So the first is yung clinical state box. These are rounded rectangles, no, which contain clinical states. So here, this comes from figure 1A, which is how to find suspects. No? And I won't go through 1A. But how do suspects become confirmed? That's a clinical state. How do they become probable? And how do they become non-COVID after all? The second symbol is decision box. And this drives the algorithm. These are the if-then statements, and they are binary. They contain a question answerable by yes or no. And yes always exits to the right, and no always exits downward. No? These are standards used by the American Society of Decision Making. Um, so that's a hexagon, yes or no. Yes to the right, no downward. So if you can see here, there are many hexagons here. And they're in, first thing to ask is, do you have PCR? And then, is it positive? If you don't have PCR, are you a previous contact? Do you have the unique symptoms like anosmia or adeusia? And third is the typical X-ray or chest CT findings, if you have them. No, the next symbol is an angled rectangle, and it's an action box. So something you do. So here, do RT-PCR. Here, do usual care if you're non-COVID ARI. The next symbol is a connection box. These algorithms can be very long. As you see, we had 7 sections of algorithms, and each one had 4 or 5. So we had 30 or 35 algorithms in all, and they're all interconnected. No? So this algorithm connects from 1A, how to find the suspect, and connects to 2B, management of moderate to severe, and tracing the contacts. We also have footnotes all over the place in the actual algorithms on the website to explain how the decision boxes are answered. And the boxes are numbered left to right, top to bottom, so that if there are questions, they are easy to discuss. So what's the advantage? Well, the advantage is if you think of a Waze map, many of you use Waze, no? You don't need to know the entire map to navigate to somewhere. So this is very good for delegating tasks from experts to non-experts. So how PISMID advises primary care providers and other healthcare workers on how to manage cases. So in this case, for example, if you have PCR, then and you do it and it's positive, then you're a confirmed case and you go to how to manage it, no? Depending on if it's mild, moderate, or severe. So you didn't need to read all the other parts of it. In contrast, if you don't have PCR, then you have questions like, were you a previous contact? Do you have the atypical but unique symptoms? And do you have the usual radiographic findings? If you do, then you can still be considered a probable case. And you don't need to know the rest of the algorithm. And you're non-COVID, if you have a negative PCR, if you have no PCR, and if you have none of these 3 sets of findings. So now what's the advantage of standardizing? No? So it allows guideline developers to delegate management. So from PISMID and other PCOM and PAFP, POGs to other users. And the algorithm users need not know the entire diagram. They can just follow it to the path that they need to go to. Say otherwise, you read the whole guidelines to find out what to do. Here, you don't have to. And also, it has been shown that flow diagrams, algorithms presented as flow diagrams, are easier to follow than prose. So many people have used these algorithms more than have actually read your detailed guidelines. In fact, your website crashed when we first posted this. No, tens of thousands of users within the first few hours, and especially within the first 24 hours. I think we had 150,000 viewers, and you had to transfer your website to another provider. So the standardized rules and symbols breed familiarity. So you may have difficulty with the first one, but the next one is easier. And they reduce confusion. And algorithms can reveal validity problems in the guidelines. No? Minsan nakita mo, paikot-ikot lang pala yung guidelines nyo. And you need to try and break that loop. And the algorithm developers know we went through this a lot in the past months. So I hope that helps you understand the algorithms. And we'll go through 6 samples from the 7 sections. and just give you a brief bird's eye view of each of them. Thank you for your attention, and back to you, Ding Dong.
Thank you, Dr. Dance, for explaining about the algorithms. So I think everyone who is listening now have an idea on how to use the algorithms. And as Dr. Dance has explained, the algorithms can be accessed in the PISMID website. So before we start discussing the different algorithms, I'd like to remind everyone that if you have any questions, then please type them in the chat box, and we will answer them at the end of this presentation. And if you would like to address your specific questions to a certain speaker, then please put that speaker's name as well in the chat box. So to begin, I'd like to introduce our first speaker who will be discussing about the algorithm on contact tracing. So I'd like to call on Dr. Aileen Espina of the Philippine Academy of Family Physicians.
Thank you, Ding Dong. Sir Tony, you will be, ano po? Si Sir Tony ang aking tagapindot ng slides. Okay. So, thank you, PISMID, and thank you, Ma'am Isa, for this opportunity to be part of your convention on the golden anniversary of PISMID. So, let me begin my presentation. Sir Tony, I cannot, hindi ko makontrol ang slides. So, can we go to algorithm 1C? Okay. So, let me begin this presentation by defining what a contact is. So, in box 2, as mentioned, andun po ni Sir Tony, andito po yung definition ng contact on the in algorithm 1B. So, just for brevity, I would like to redefine for everybody who can be considered as a contact. So, a contact is a person who has been knowingly or unknowingly, pwedeng hindi niya alam, who has been knowingly or unknowingly exposed to a probable or confirmed COVID case. So, I will repeat, a contact is any person, regardless of profession, status, whatever. Hindi ho namimili ang COVID kung sino ang magiging contact. Any person who has been knowingly, alam niya, or unknowingly, hindi niya alam, exposed to a probable or confirmed COVID case, regardless if the index patient, kung kanino siya na-expose, is symptomatic or asymptomatic. And the exposure happened 2 days before the onset of symptoms in the case of asymptomatic index patient, or 2 days before the positive test was documented, and in the succeeding 10 days thereafter when the patient is already symptomatic. Okay. So, medyo kailangan po kasi nating klaruhin yun. Because of this confusion, contact tracing has somehow become the Achilles heel of the whole COVID response. This has been disregarded as everybody was more focused on taking care of cases, yung mga confirmed, yung symptomatic na po, yung nagpapakonsulta, rather than looking for the contacts and preventing further spread to other people by nipping the chain of transmission in the bud. It is only by identifying people who have been exposed to a case early so that these people can be quarantined early and prevent them na manghawa pa ng iba. That is forward contact tracing. Ngayon, if we are so intent on doing really an outbreak investigation, may tinatawag din hong backward contact tracing. Ito po yung hahanapin naman natin saan nahawaan yung pasyenteng minamanage mo ngayon. Why is this important? Kasi yung nakahawa po halimbawa sa akin, malamang may mga nahawaan din po siyang iba. At yung mga nahawaan niya, kailangan hanapin natin at kung sino pa yung posibleng nahawaan nila. Kaya nga po sinasabi ni Mayor Magalong, for every one case, based on their experience in Baguio, they were able to identify 37 contacts. So imagine, isang tao lang, meron siyang 37 contacts. And then these 37 will have 37 more. So, actually, hindi naman siya nakakatakot. Hindi siya ganun ka-overwhelming. Because there is actually a golden window of opportunity. Because if you recall the natural history of illness of COVID, people who are exposed to an index case are not immediately infectious upon exposure. Okay? They only become infectious, as I've said, 2 days before the onset of symptoms. Kaya lang, sadly, we were very reactionary in the beginning. So, we were just focused on managing the cases. Kaya nga, naisip natin na the hospital was the front line. When in reality, yung nasa labas ng ospital ang mas nakakatakot dahil patuloy silang naghahasik ng lagim. Not to make any excuses, we were indeed somehow caught by surprise. And we also didn't know enough of the virus as to its efficiency of transmission, no? And we didn't have enough testing capacity, nor we have the ability to harness ICT to enhance the response. So kaya medyo nahirapan talaga tayo in the beginning. But now, we already have testing capacity. We have surveillance and we have contact tracing apps. We now have the ability to enhance traditional surveillance methods like yung PIDSAR. So, we're now moving into events-based and case-based surveillance, and we're now using digital contact tracing. There is no longer an excuse for us not to play, as doctors, not to play a more active role in contact management with our individual patients and their families. We need to understand now how to do efficient and effective contact management. And this is what Algorithm C is all about. So, in this algorithm, we have identified 3 possible modes of exposure. Una is by travel. Kasama po dito lahat, no? Nakasabay mo sa MRT, nakasabay mo sa jeep, nakasabay mo sa bus, nakasabay mo sa eroplano, sa barko. But for simplicity, under exposure by travel, we will be limiting this kasi yung mga nakasabay sa MRT, ilalagay po namin siya under box number 4. Or hexagon number 4. So for hexagon number 3, this is mainly focused on APORs or authorized persons outside of residence, LSI, locally stranded individuals na uuwi na po ng probinsya, returning OFWs, tapos po yung mga kamag-anak natin na bibisita sa atin ngayong Pasko, or yung mga kamag-anak natin na galing abroad. So, what do we do with them? Sir Tony, pakiclick po. So, pag oras na dumating po sila sa atin, so, this is actually more for people who will be staying long with you. So, LSI, kasi permanente na po silang uuwi, yung ating returning OFW. So, ang idea po is, dapat silang i-quarantine. Okay? They should quarantine for 14 days. Pero yung mga returning OFW po natin, meron pong separate IATF resolution on that, wherein they are being tested at the port of departure, and when they arrive in Manila, they are quarantined in accredited facilities by the Bureau of Quarantine, and then they undergo another round of testing before they are allowed to board a domestic mode of transportation, whether it's a plane, a boat, or a bus, to go home to their final port of destination. Doon po sa mga bahay nila. So, pag uwi po nila, pagdating po ninyo, wag mo muna ninyong salubungin yung pasalubong. I-quarantine po muna natin sila, no? So, ang unang tanong, yung bahay po ba ninyo may sariling kwarto? Kung saan po, doon po sila mag-stay lang muna. Dapat po minimize po muna yung mga beso-beso, mga mano, yakapan, halikan pagdating nila. Kasi mahirap na po. Hindi na natin alam kung sila po ay na-expose sa kanilang katabi habang sila po ay nagbibiyahe. Okay? Pag wala po, walang kwarto, and this is a mandatory, most LGUs have made this mandatory that all of them must be admitted to the government facility quarantine, government quarantine facilities. Sumunod po tayo doon. Ito po ay proteksyon hindi lamang po sa inyo at sa inyong pamilya, kundi po sa inyong komunidad. Okay, kung kayo po ay may kwarto, ang tanong, kaya nyo bang mag-monitor? Alam nyo ba? Kung kaya po, pwede po sa bahay. Pero kung hindi naman po kaya, again, we advise admission to a facility quarantine. Ngayon, kung talagang walang kwarto o gusto lang niya, kahit may kwarto sila, kahit kayang i-monitor, pero iniisip nila, ay hindi, magpapa-admit lang ako kasi baka mahawa ko yung aking mga anak o yung aking nanay na matanda na. Tama po yun, ano? Kasi dapat tingnan din natin yung mga kasama natin sa bahay. Huwag ho nating ipilit ang gusto natin sapagkat sa panahong ito po, ang kagustuhan natin para sa ating pansarili ay mas nangingibabaw po ang kaligtasan ng ibang tao. Huwag po natin silang ilagay sa alanganin dahil po sa ating pagpapabaya o dahil po ipinipilit po natin yung gusto po natin. So, we have heard reports of people preferring to be admitted. So, sila po Ngayon po, kung may kwarto, kaya na mag-monitor at ayaw magpa-admit, then we suggest that maybe you can coordinate with your local COVID task force kasi yung iba po meron po talagang ordinansa na bawal. Ngayon po, mag-quarantina. Ano po yung imo-monitor natin habang nagka-quarantine? Babalikan po natin yan mamaya. Now we go to the second type of exposure. This is exposure to a known case or a probable case saan? Doon po sa bahay, sa workplace, public spaces, and public transportation. Lahat po ng kasama natin sa bahay ay considered na close contact. Bakit po? Kasi syempre, we are talking together, eating together. Alam nga naman, yung asawa mo, hindi mo katabi sa pagtulog. Yung mga anak mo, hindi mo hinahalikan. So, pag meron na pong isa dyan na nagkasakit sa loob ng ating family bubble, yung sa loob po ng ating household, we consider now all the members of that household to be close contacts. Therefore, even if the index patient has been transferred to a government isolation facility, it is ideal for the entire household to be placed on household quarantine for the next 14 days. Kailangan po, we observe po natin for the development of any of the symptoms related to COVID. Okay? So, sa workplace naman po, how can the workplace monitor? DOLE requires daily health declarations. The HR can also monitor yung mga nagsisick leave at yung mga konsulta po sa clinic. So, yun po, dapat po talaga, at yun din po ang nakasaad doon sa Joint Memorandum Circular ng DTI, DOLE, Civil Service, and also DOH, that the workplace, and it's also in the workplace handbook, should have its own active contact tracing activities in the workplace. Now we go to public spaces. Paano mo malalaman na yung nakatabi mo sa mall, o nakatabi mo sa simbahan, o nakatabi mo sa palengke, may COVID pala. Pumunta ka ng Divisoria, hindi mo alam. Dito po ngayon papasok yung need na tayo po ay merong mga digital contact tracing apps. Kasi po through that, and HPAAC is working with government agencies on this, in coming up with a mechanism by which all these data capture systems like QR codes, RFIDs, contact tracing apps, all the data being gathered by all of this, and even the laboratories and the hospitals, will go into one platform para po malalaman po natin. Halimbawa, ako po nagpunta ako ng I was in Robinson's Galleria the other day. So, paano ko malalaman na yung nakatabi ko pala doon sa in the table where I ate, malapit sa akin was nag-positive. So yun po yun po ang importante sa contact tracing. Now, in the event na gumagana na po yung ganun, at nakatanggap kayo ng text, sasabihin sa'yo, oh, Pauline, you have been exposed to a probable case 2 days ago while you were in this mall. What do you do? Tanungin mo kagad ang sarili mo, am I a close contact? So ito na po, box number 6. So dito po papasok ngayon ang apat dapat. Tanungin mo kaagad ang sarili mo. Teka lang, nasaan ba ako? Saan mga lugar ba sa mall ang pinuntahan ko? Sino ba yung mga nakatabi ko? Meron ba ako nakasalamuhan na talagang super dikit kami? Nakasuot ba ako ng PPE palagi? Lahat ba ng kinausap ko sa mall nakasuot din ng PPE? Gaano katagal kami nagchika ng kaibigan ko? So if it happened in an enclosed space, na pangit po ang ventilation, kulob na kulob, nakatakot po yun. At kung nangyari po yun habang kayo ay kumakain ng kaibigan mo at nagtanggal kayo pareho ng mask at malapit kayo sa isa't isa, nakatakot po yun. Tapos, gaano katagal kayong nagsama? Ang apat dapat po nagsasabi, hindi ka close contact pag ang encounter or exposure happened in a space that was well ventilated. So, the first A of apat dapat is air circulation or adequate ventilation. Then we have P, physical distancing. Dapat po mas malayo, mas mainam, mas maganda, So, dapat wag muna tayong sikit-sikit, Sa amin sa Bisaya, sikit-sikit ang tawag namin diyan. Wag muna tayong masyadong dikit-dikit, Then, palagi ho nating isuot ang ating mask at face shield whenever we go out properly, So, yun ang tatanungin natin sa mga pasyente natin habang tumatawag sila sa iyo at nagpapanik. So, apat dapat, air circulation, physical distancing, always wear the PPE, and the exposure time. So, dapat less than 30 minutes. So, pag hindi po yun, pag okay siya doon, hindi siya close contact. So, ayan. Click na, Sir Tony. Hindi daw nagbabago yung slide. Ayan. So, hindi ka close contact. But nonetheless, dahil ito pong apat dapat ay hindi naman perpekto, at minsan hindi natin siya kayang gawin talaga. So, papahiritin natin ang pasyente natin. Sabi natin, sige, 3 out of 4, okay na. Paano kung 2 out of 4 siya? 2 lang yung nagawa niya, close contact po yun. Okay? Pag nagawa niya yung 3 sa 4, hindi siya close contact. But nonetheless, para po makasiguro tayo, they should limit their exposure to the most at-risk population or to the vulnerable. Ngayon, kung tayo po ay nakatira sa isang community where there is sustained community level transmission at hindi na po natin alam kung sino po yung na-expose sa ating mga neighbors, mga kamag-anak, kapamilya dyan, nakatabi natin sa bahay, then it is better that you should subscribe to the standard public health preventive measures. Okay. Sir Tony, next slide po. Okay. Now, so, lahat po ng may exposure, we will begin monitoring. And if the patient will develop signs and symptoms of COVID in the next 14 days, okay, though meron pong lumalabas ngayon from CDC, decreasing this to 7 to 10 days, but we're still studying it, then you will have to refer now to figure 1A of this algorithm so that you would know what to do with the patient. So, kung wala pong ng symptoms na mangyayari, then you can now end the quarantine. Yun lang po. Maraming salamat and you can download this from the PISMIG website.
Thank you very much, Dr. Aileen Espina. So, thank you for explaining very well how contact tracing is done and what is the importance of the 3 different ways by which you become a contact of a person infected with COVID-19. Of course, there are a lot of systems that need to be fixed regarding contact tracing. How do we know, for example, if we go to a mall, if we have been exposed to someone who has the disease? And personally, parang ayoko na nga pumunta ng mall kasi nahihirapan ako mag-log in every time I go inside and inside the different stores as well. So I don't see the need, no? Parang nag-a-apply tayo sa raffle. Hindi naman tayo nananalo. Sana hindi tayo manalo ng COVID-19. But anyway, that was contact tracing, and we already received a number of questions in the Q&A box. So I'd like to remind our speakers to keep your discussions between 10 and 15 minutes length, and then to please answer the questions in the Q&A box. You can answer them there, or you can also answer them live. Later on po, after everyone has finished their presentations, then we will have an open forum, and the panelists can also discuss what were the questions asked, no? So that everyone can hear. And then please be reminded that the unified algorithms can be found in the PISMID website, and it is a living document. So it can be changed or updated depending um, on the new guidelines that will be published later on. So at this point, I would like to call our next speaker, who will be talking about primary care. He's no other than the current president of the Philippine College of Physicians and past president of the PISMID, Dr. Mario Panaligan.
Good morning. Maraming salamat syempre kay Dr. Aileen Espina. I really enjoyed again listening to you after that long talk. Definitely, I understood even those algorithms more today. No? So I'm tasked to discuss algorithm 2A and 2B. Next. So figure 2A will show you, of course, the algorithm on the community-based management of asymptomatic individuals with confirmed COVID-19. So this is as of November 7 of 2020. So ang critical dito, syempre, number one, kailangan confirmed. And usually when you say confirmed, it requires, of course, the COVID PCR testing result. No? So pag positive yon, no, syempre, kailangan wala ring symptoms. No? Ibig sabihin, walang manifestation o wala malang kahit anong sign that will tell us that the patient has a possible or has COVID-19 infection. No? So, ibig sabihin, naglalakad lang sila, tapos wala naman nararamdaman. Ang problema, na-confirm sila, maaari kasing naging bahagi sila nung screening dahil naging contact sila ng isang confirmed COVID-19 patient dati. At nangyari, nung tinest siya, nag-positive siya. So, ang unang gagawin, syempre, when you talk about confirmed COVID-19 asymptomatic individual, so, syempre, importante na magkaroon ng contact tracing. No? Syempre, nabanggit kanina, no, ni Dr. Espino yung forward at saka yung backward, no, tracing. No? Siyempre, importante, sino-sino ang posibleng nagkaroon ng contact sa kanya. No? At pangalawa, sino pa ang mga posibleng na-expose naman sa kanya. So, forward, backward. No? So, importante malaman kasi ang goal natin dito is really to minimize the spread of the disease. And therefore, it is very, very important that we will be able to know and, of course, identify who were exposed, no, to that particular patient, yung nauna at saka kahit yun sa kanya. And then, from that patient and from that step, no, syempre, we will now move to the decision boxes, yung mga tanong na answerable by yes or no, as mentioned by Dr. Dance earlier, no. Syempre, dahil confirmed siya, no? Siyempre importante malaman, no, kung meron bang pwede siyang tulugan o tigilan sa bahay na hiwalay sa ibang kasama pa, no? So this meron bang available separate room in the household, no? Siyempre tatanungin din yung isa pang question, mahirap ba, no, mamonitor yung tao na yon, no? At kung sakali, magkakaroon man ng problema kung sa pagbabantay, biglang magkasakit, no? So, siyempre, no na naman yon, no? Tapos kung um, ang pasyente naman, syempre, kung gusto ba niya na magstay na lang sa quarantine facility, pero syempre, kung hindi, then puro no yung magiging sagot. Pero, kung kahit isa dyan, no, ay yes ang magiging sagot, so ang susunod na hakbang, no, syempre, titira o i-refer natin o pupunta siya sa COVID center or sa quarantine facility, no, ng syudad, no? So importante kasi ng mga pasyente kahit asymptomatic, no, kahit wala silang nararamdaman, dala-dala nila yung virus, and therefore they can actually transmit or transfer this infection to other people if they won't get isolated, no? So importante iwalay talaga sila, no? So ang importante pabantayan, no? Kahit asymptomatic, may danger na mag-spread, no, sa ibang tao. Pero siyempre kung lahat naman, no, negative, no, kung lahat sinabi niya meron akong separate na room at pwede akong mabantayan, pwede akong kumonsulta agad, no, kung sakali meron akong maramdaman, no. So siyempre pwede naman sa bahay, provided that that patient will be in a different room, kasama pa yung ibang mga tao doon, pero hiwa-hiwalay sila, no. Everybody has to be quarantined. Everybody has to stay there for the next 10 to 14 days. No? Next po tayo. So yun na, iko-quarantine household, no? Sabi ko nga, lahat, no, nasa bahay, dapat naka-quarantine, hiwalay, para nga hindi kumalat ang sakit, no? Samantala, siyempre, pag nasa COVID center naman, o kahit na yung nasa quarantine, dahil wala silang lahat na symptoms, no? Walang kahit anong sign that would tell us that there is COVID-19 infection, kailangan talaga yung pagbabantay. Bakit? Kasi ayaw natin silang lalala. No? Alam naman natin na pagka lumalala at na hindi agad nadala sa ospital o hindi agad natugunan o biglang na-manage ng tama, pwede lang ikamatay dahil magiging grabe yung sakit. No? Pero siyempre, habang binabantayan, no, importante, lagi natin pinapaalalahanan. No? Kasi madalas tayo makalimot no? Tayo mga Pinoy kasi gusto talaga natin lumalabas, makipag-usap. Kaya na binanggit ni Dr. Espino, yung beso-beso. Gusto natin lagi nagkikita-kita. Pag nagkita-kita, nagyayakapan pa. Kung maaari talaga, pagbabawalan yun. No? Importante, ma-monitor, mabantayan, at para masigurado na hindi magkakasakit. No? So, yun yan ulit sa mga susunod na 10 hanggang 14 na araw kung magkakaroon ng sintomas. Kung magkaroon, then babalik tayo sa 1A. Doon naman, i-manage natin ng tama kung paano natin gagawin. Pag wala naman naging sintomas, siyempre, tigil. No? Titigil na natin yung pag-monitor at pwede na natin desisyonan o pwede mag-decide, no? Yung tao kung anong next ang gagawin na nakasulat dyan, no? Sa figure 5B. No? So, next po tayo. So ito, pinapakita ko lang na lahat, no, ng mga algorithms na banggitin kayo ni Dr. Tony Dance, incorporated yan, no, doon sa unified algorithm na mada-download natin ng libre, makukuha natin kopya sa PSMID webpage. No. So lahat yan interconnected. No. So ito yung figure 1A para malaman nyo kung anong dapat gawin sa mga pasyente posibleng may sakit. Next slide po. So ito naman, no, yung figure 5B, siyempre, wala na nga nararamdaman for the next 10 to 14 days, no? So, siyempre, pagdidesisyon na kung pwede bang maklear o makabalik sa trabaho, no? So, pero siyempre, may pagtatanong pa rin na gagawin dyan, no? Siyempre, importante masigurado natin na itong tao na ito ay ligtas at walang sakit at hindi makakahawa sa ibang tao. Kung titignan nyo, may mga connection box din dyan, no? Meron babalik ulit sa 1A, may babalik ulit sa may 1C, tapos may punta sa 2A ulit. So, babalik sa pinag-usapan natin kanina. Next slide po. So, yan yung 1C para sa contact na na-discuss kanina ni Dr. Aileen Espina. Next slide. At ito naman po yung 2A na discuss o binanggit ko kanina. No? Sige po. Next slide na po tayo. Doon naman po tayo sa figure 2B, management of mild and moderate cases. No? So kung titingnan natin, siyempre, ang clinical status niya, siyempre importante malaman natin kung ano yung mga dapat na malaman natin kung kung kailangan na ma-work up o matingnan, no, yung mga suspect cases. Ano ba yung suspect cases? Siyempre, ito yung mga posibleng na-expose, no? At saka pangalawa, may sintomas, no? So pagka may sintomas ka, kailangan malaman natin, siyempre, kung mild or moderate yan, no? So basically, it's important for us to know whether these patients or individuals need to be referred immediately to the hospital o kung pwede rin namang sa bahay na lang as discussed earlier. Pero siyempre may mga questions pa rin tayo sasagutin. Actually, ulitin natin yung ginawa natin kanina. So, importante siyempre malaman muna natin yung kung sino-sino pa ibang na-expose at naging contact niya. Pangalawa, pati mga tanong kanina kung meron ba siyang tutuluyan na hiwalay. At pangalawa, may magbabantay ba o pwede posible ba siya mag-monitor sa sarili niya. At pangatlo, siyempre, kung gusto ba niya talaga, doon na lang siya sa quarantine facility. Kasi kung yung mga gano'n naman, siyempre, pwede naman siya doon na sa quarantine facility. Pero may option din naman sa kanya kung talaga masisigurado na magbabantay sa sarili niya. At meron ding tutugon kung sakali. No? Kung sakali meron pa siyang ibang mga sakit. No? Kasi wala namang pinipili nga itong COVID-19. No? So, mas malala pa nga pagka yung tinatawag natin nagkasakit yung sinasabi lang vulnerable. No? Pag sinabi vulnerable, ito yung may mga iba pang sakit gaya ng diabetes, sakit sa puso, sakit sa high blood, at pati yung mga may cancer. No? Posibleng sila yung magkasakit and therefore, importante na itong mga taong nito may magbabantay talaga kung gusto nila sa bahay sila. No? Pero siyempre, doon din naman sa quarantine facility, importante din ipaalam yun. No? Importante kasi matugunan agad kasi ayaw natin sila yung lalala dahil importante din naman na magamot din sila ng tama. No? So, ang mild mild probable or confirmed cases, siyempre, kapag suspect pa lang sa umpisa, kailangan ma-work up muna kung ma-test, kung positive or negative. Siyempre, kung wala pa rin testing, siyempre, importante, babantayan nga, kaya tinatawag silang probable. Pero pag nag-confirm na at nag-positive na, siyempre, positive na yon. No? So, ulitin ko, babantayan kung hindi sobra o madami yung mga naramdaman o kung hindi lumalala ang ubo, kung hindi lumalala ang lagnat, at pati yung pagtatae, siyempre, importante rin tignan. No? So, maraming mga manifestations o mga sintomas ng sakit na ito. So, kasama-sama yun sa pagbabantay. Next po. So, kung titingnan nyo, ganun uli, no? Pwede naman sa bahay, pwede rin sa quarantine facility, no? But importante, no? Pagbabantay. Kasi yun ang importante kasi hindi natin alam, no? Kung sino-sino ang posibleng lumala, no? Kahit sinasabi natin, may mga iba pang sakit ang madalas lumalala, meron din mga tao na wala naman dating sakit pero posibleng maging malala. So, bukod doon, sa pagbabantay, kailangan na rin bigyan natin ng tulong, no? Para sa ubo, sa lagnat, at kung nagtatae, siyempre, kailangan din sila mabigyan ng rehydration solution. Importante, hindi sila matuyuan o ma-dehydrate. Kasi siyempre, ayaw din natin magkaroon ng komplikasyon. No? Tandaan natin, ang COVID-19, lahat ng organs posibleng maapektuhan, pati kidney. So, importante mabantayan yan. No? At importante, mabantayan din natin ang paggaling nila habang tumatagal. No? Pag sinabi natin 10 to 14 days din ng observation period, tingnan din natin kung mawawala yung mga sakit. No? Kasi sa ngayon, pwede naman natin na silang bigyan ng clearance kung sakali mag-improve na at kumaling na, wala nang nararamdaman sa susunod na mga 10 hanggang 14 na araw. Tandaan natin, meron mga tayong policy ngayon, no? Lalo na sa DOH. No? Hindi na kailangan ulitin ng testing. Basta importante, mabigyan lang natin ng sapat, no? Na pag-aalala at saka sapat na pag-manage, no? Sa mga pasyenteng ito. Over na po sa inyo. Ito yung discharge criteria. Okay. Thank you.
Maraming salamat, Dr. Mario Panaligan. So, alam na po natin kung paano ginagawa yung contact tracing. And then, we've also learned about how to treat patients in the primary care setting. So, papaano naman po kung kailangan ng i-admit ang pasyente, no? Hospital care. So, how do we manage COVID patients in the hospital? So, for our next speaker, I would like to call the current Vice President of the Philippine College of Physicians and the past President of Philippine College of Chest Physicians, our pulmonologist, Dr. Maricar Limpin.
Thank you. Thank you, Ding Dong, and good morning to everyone. First of all, I'd like to thank PeaceMed for inviting me to their golden anniversary convention. So I'd like to discuss about hospital care of COVID-19 patients, whether suspect, probable, or confirmed. And this will involve management for algorithms. So first would be the management of moderate to severe COVID-19, and then advanced life support, as well as the ARDS and sepsis. Now you can go. Yes, next slide. Thank you, Tony, for doing this. Okay, so first is, of course, as we have already discussed, for the mild COVID-19, you don't need to have to admit them. So basically, the ones that we're going to admit are patients who are already moderate to severe or critical. And the first thing that we need to do is, of course, once we see patients with COVID-19, either confirmed or suspect or probable, then we usually do imaging techniques immediately. And if we will be able to see the presence of infiltrates on chest X-ray, then basically that will actually tell us that these patients are not just mild COVID-19, but would probably have at least, at the very least, moderate COVID-19. And then the next that we need to take a look at will be the respiratory situation of the patient. So whether these patients will need O2 support or, and this can usually be seen when we look at the auto saturation of the patient. So if the auto saturation is less than 93 or equal to or less than 93 at room air, then most likely this will actually be patients who will either be severe, and usually if we look at the chest X-ray, these patients would actually have more than 50% of the lungs will be involved. So, and that is why these are patients who will actually require higher oxygen support, and therefore will need the use of dexamethasone, as they have actually been shown in the recovery trial to really help our patients improve survival. In fact, for patients who have O2 but not on mechanical ventilatory support, there is a reduction by 1/5 of mortality. And for those on mechanical ventilator, there is a reduction of 1/3 in mortality among patients who were given dexamethasone compared to those who were only placed on the usual care. So, and for patients who have severe, then these are patients also who would probably be needing a low molecular weight heparin. As we have seen in patients with COVID-19, one of the most striking pathophysiologic mechanism that we have seen is the presence of microvascular thrombosis. Now, the thing probably that you need to do for you to be able to determine whether what you need to give is just prophylaxis or active treatment, then you need to request for a D-dimer. If the D-dimer has actually is increased by 3 to 4 times, no, that of the normal, then these are patients who will most likely benefit from active treatment. But an increase only, but not lower than 3 times of the normal, then these are patients who will be needing prophylaxis, no, using your low molecular weight heparin. And then at this point, these are also patients whom you might want to consider giving remdesivir, and then of course refer them to the pulmo service or to the critical care service, and then consider also enrolling them in randomized controlled trial if your institution has a clinical trial team, or and then, but if not, then probably you can consider giving investigational drugs for compassionate use. Investigational drugs that can be used, no, for compassionate considerations will probably include the use of convalescent plasma and other drugs like your immunomodulators, or even the administration of hemoperfusion, no, if it is warranted. But of course, no, I would like to remind everyone that before we give any of these investigational drugs, particularly the immunomodulators, the tocilizumab, or even considering hemoperfusion, you have to monitor the inflammatory markers. And please do not immediately consider using your immunomodulators or your hemoperfusion if your patient is still on the first week of illness. Because if the patient is still on your first week of illness, that is not the time when you would probably be expecting already the cytokine storm. Cytokine storm is actually expected on the second week of illness of COVID-19. Now, what about the less severe, no, which is the moderate? In moderate, actually, this will require an O2 saturation of, these are patients who will have an O2 saturation equal to or greater than 94% at room air. And if and when they will be needing O2 support, the O2 support is really quite low. Maybe 1-2 liters will be enough, and this will be enough to address, no, the hypoxemia of these patients. I'd like to just emphasize that at this point, when your patients have moderate COVID-19, you still have to address the hypoxemia of the patient, even if it will be just in the form of low O2 support, because we have to remember that patients whom we see who will be in moderate or even in severe can actually slowly progress to the more severe type of COVID-19. So what we have actually seen in most of the patients that we are seeing with COVID-19, the first and foremost thing that we need to do is address the hypoxemia. And if you do not address the hypoxemia, even if when they have moderate, these patients will probably progress to severe or even to critical COVID-19. So what the reason for that is because of the increased transpulmonary pressure that we see brought about by the increase in the tidal volume that is being generated by the patient as a form of response to the hypoxemia that it is experiencing at that particular time. Therefore, for moderate COVID-19, very important that if the patient, even if they are only slightly hypoxemic, we need to give them O2 therapy. And then consider enrolling them in RCT if you have a clinical, if your institution it has a clinical trial team, and then probably consider also compassionate the other investigational drugs for compassionate use, which may be probably using favipiravir, no? So favipiravir is actually has been shown to be effective only in mild cases of COVID-19. So probably you can also make use of favipiravir. But what is important in patients with moderate is to ensure that you are able to address whatever hypoxemia the patient has at that particular point in time. Next. So, and then, of course, we have to remember that even if patients would probably be just in moderate or in severe, at any point in time, this patient may actually suddenly go into cardiac arrest. Okay. Why? Because one of the complications that we see in COVID-19 is myocarditis, and sometimes the patients might actually go into many forms of arrhythmias that can be fatal. So suddenly you can see patients who probably are in the recovery phase, then suddenly dropping down dead, really dropping down dead, and therefore you will probably be seeing them in CPRS. So if CPRS, you go to the algorithm for CPRS. Now, patients can also go into ARDS or in more critical severe severe COVID-19. Nawala ka, Tony? Yes. So now, if you have a patient who went, next slide, Tony, then you go to the algorithm for the critical ARDS, or what we call CARDS, no? And patient can also, while in CARDS, no, can actually, these are patients who are most likely to develop also sepsis, particularly if they are on mechanical vent for so long. So they can go into sepsis or in septic shock, and therefore we now go to the algorithm for critical sepsis. Now, if there is improvement, then we also go to algorithm for improving conditions of COVID-19. Next slide. Now, this is actually the algorithm for those who will develop CPRS, no, for our patients with COVID-19. So once they go into CPRS, the first thing that has to be determined is whether the patient has advanced directive. Advanced directive only means that the patient has, you already know the plan of the patient on whether they want to be intubated or they want to have further aggressive CPR, no, aggressive measures, aggressive intervention to be done for them in case that they went into a state wherein there is the likelihood of recovery is very low. If the patient has advanced directive, then there is no problem. If the advanced directive favors resuscitation, then we initiate CPR. Okay. Now, if there is no advanced directive, then the ones that who are going to, then that we need to actually determine whether there is presence of a proxy decision maker. So the proxy decision maker will be the immediate family. No, if it's still married, that should be the spouse. No, if the spouse is already dead, then that will be the children. The first in line will be actually the eldest will actually be the ones to give the decision on whether the team can actually proceed with CPR or not. Okay, so usually, madali naman ho yan, ano? There will always be a decision maker. Now, the most important thing here probably is to ensure, especially for COVID-19 patients who are admitted in the hospital, we have to ensure that there is always an open communication between us and the relatives of the patient. We know that patients are not allowed in the hospital once the COVID-19 patient is admitted to our hospital. Therefore, just to make sure that there is an open line, no, so that we can ask them for anything, no, and if there is something that we need to do with the patient. Now, if there is presence of proxy decision maker, then we discuss with the relatives whether there is a higher chance of recovery or whether recovery is unlikely. If recovery is likely, then we have to initiate CPR, no? If the patient, we can actually initiate CPR. However, if the recovery is unlikely, and then the relatives decide not to pursue not to pursue CPR, then we can actually consider DNR and then postmortem care. Now, problem will be if there is absence of a decision maker. In the absence of a decision maker, then it is the medical team that has to decide. And again, the decision of the medical team will depend upon whether the recovery of the patient is likely or not. If it is unlikely, then the recommendation is to consider DNR, no, for the patient. And then after that, then postmortem care. Next, Tony. Yeah. So in doing your CPR, we have to take note, no, patient can actually be already on mechanical vent when he develop cardiac arrest, or patient may not actually be on mechanical vent. Okay, so if the patient is on mechanical vent, then there's no problem. What we need to do is just initiate the CPR while maintaining the patient on mechanical ventilation. Now, there are now newer technologies on mechanical vent wherein we don't really need to remove the patient from the mechanical vent. This is what we call the CPR ventilators. And with CPR ventilators, the giving of the positive pressure is actually synchronized with the chest compressions. And therefore, you are able to avoid some of the pulmonary effects that might happen when there is no synchrony with the chest compression that is being done during CPR. Now, if the patient is not on mechanical vent when the CP arrest happened, then you need to consider whether early intubation is still possible. If it is still possible, then you do early intubation. Please note that when we talk about intubation in COVID-19, this has to be done by the most experienced personnel. And the most experienced definitely in the hospital will be the anesthesiologist. Again, once intubated, put the patient on mechanical vent, no? And then put the patient on mechanical vent. The use of a bag valve mask is no longer being recommended, as there is the danger of aerosol transmission to the healthcare workers that are attending to the arrest of the patient. Probably at this point, if the early intubation is not possible, then all that you need to do not do any mouth to mouth, no. So just do the hands only CPR. So I think if once the CPR, we continued the CPR and the patient was revived, then we need to continue our critical care to the patient, continue our monitoring, do whatever that needs to be done, maybe chest x-ray, or do some of those laboratories, request for some of those laboratories, and bring the patient to the ICU. If the patient did not revive, then we provide the patient with postmortem care. At this point, before I continue my any further discussion of the algorithm for those hospitalized patients with COVID-19, I'd like to probably request Pauline to come in, as she probably has something to say. Pau, can you?
Yeah, thank you, Dr. Maricar. I just like to add, because there's just this recently released 2020 guidelines, October 21, 2020, they released these new guidelines for resuscitation. And we all know that there are many different scenarios during resuscitation. And unfortunately, in the emergency department, we don't have the luxury of knowing the course of the patient when they come in at the ED. So it's a totally different scenario when you're presented with a patient with whom you don't know the story first, because the patient is already arrested and the victim is that presumed COVID until proven otherwise. So
Yeah.
it's not explicit in the algorithm. So there may be really indications for arrhythmia. So it's not explicit because we just wanted to show in the algorithm when it was developed that it's about doing resuscitation in COVID. But we also need to understand that there may be other indications for the cause of the arrest, Dr. Maricar, so like arrhythmia, and
Yeah.
that there may really be indications for defibrillation, but we just did not put it there. So it's not explicit, but we need to also understand that the arrhythmia may be easily reversible. So if there's an indication for arrhythmia, then we should also defibrillate, or if it's shockable, for priorities of intervention. And also, Doc, for new technology, since you mentioned CPR ventilator, just add quickly that there's also, if there you have a mechanical compressor, you may use the mechanical compressor if you have it, rather than do the manual compressor. At least you have hands free to do other things, and it's safer. And lastly lang po, Doc, dagdag ko lang din, limitation of the exposure of your healthcare workers by also decreasing the number of your code team members. So maybe in a nutshell, dun na po, Doc, idadagdag ko po. But then also just that in the ED, we have a different story when we really don't know what we're dealing with. So we always emphasize that safety first of your team, while saving the lives of others. So yun lang po, Dr. Maricar. Thank you po for the moment po.
Yes, thank you, Pao. And I agree, no, we need to really limit the number of healthcare workers that will provide the CPR to the patient. But the defibrillators is actually part of the CPR, the ACLS. So definitely, if the rhythm not on the cardiac monitor will show the presence of VFib, then we need to defibrillate. As long as there is no DNR, no? Because
Yes,
sometimes the relatives might actually want a DNR. So very important to actually be talking to the relatives, no?
Yeah. Thank you, Doc.
Okay, thank you. So next slide. Now, this is actually the algorithm for patients with critical ARDS, no, or what we call the COVID ARDS, or cards, no. So patients who have cards are said to really have are those patients who probably develop already respiratory failure and who will be needing mechanical ventilation. So you will be able to see that these patients are already in ARDS because there is definitely deterioration, no, of the respiratory condition of the patient. So how will you know that the patient's condition is deteriorating? You look at the very most simple things that you need to do. So just look at the respiratory rate, look at the O2, the PO2, no. So that means you need to be getting your blood gases so that you will be able to see the PO2, or even just by means of your O2 saturation. But at this point in time, sometimes it's really very difficult just to be relying on your O2 sat, no? And then patients might also have problems, no, with their blood pressure, with the hemodynamics. So the hemodynamics may actually be very poor. So the systolic blood pressure may be 90. If the answer to all of this, the RR is greater than 30, less than 92, the BP is less than 90, then you need to start the auto support, no? So that is very important, no, the oxygen support. But usually patients in ARDS, auto support will not be enough, no? So if by 6 liters nasal cannula, the the oxygenation of the patient is still poor, meaning to say they persist to have an O2 of an O2 less than an O2, PO2 less than 92, or you can now try to compute for the PF ratio that is less than 200 or even less than 100, then most likely conventional O2, the O2 that the nasal cannula will not be enough. Now, for some institutions who probably do not have the high flow nasal cannula, then you can actually make use of the face mask, the ordinary face mask. But then again, you have to make sure that when you do all of these things, no, because there is the possibility of aerosol transmission, you have to do this at an isolation room. And when we say isolation room, then that means that that room should be provided with a negative pressure. In the absence of a negative pressure, then you have to make sure that that room has adequate ventilation. You open the windows, no, make sure that the patient's bed is near the window, so that even if there is aerosol transmission, that can actually dissipate into out to the outside environment. Okay, so that I think is the most important. Now, if the RR, the PO2, and the systolic blood pressure is okay, acceptable, then you just continue with the supportive support. Now, let us say that with auto support is still upon evaluation, so you need to closely monitor your patients. So every hour or every 1 to 2 hours, you need to evaluate again. And then if you are not able to provide adequate oxygenation, then you can probably place your patient on high flow nasal cannula. When in high flow nasal cannula, you still have to provide for your, you still need to monitor. So you monitor using your ROX index, no? Your ROX index, the formula for your ROX index is your auto saturation over the FiO2, no, over the respiratory rate. No. Now, these are the ROX index that you need to always look for. No, if the ROX index will be at 2 hours is less than 2.8, that is very low. For 6 hours, less than 3.47, and at 12 hours, less than 3.85, then these are patients who are most likely candidates for invasive mechanical vent. No, so easily dito pa lang sa algorithm natin, no, if you have a ROX index that is less than 4.88, no, nandoon na yan sa medyo malapit, no, and therefore you might have to really closely monitor these patients, because these are patients who would probably eventually be intubated. If the ROX index is high, then you can actually continue your auto support. You can continue your high flow nasal cannula, no, and then if as long as you have no other indications for intubation. Okay, so if you have other indications for intubations, the other indications for intubation will be in terms of decreasing decreasing sensorium, or changes in the sensorium, or your blood pressure drops, no, your hemodynamics become compromised, then you, even if the ROX index is good, no, you still have to intubate the patient. No, kapag pumangit na ho ang BP, there is no way that you will be able to avoid intubating the patients. Kung hindi naman, then you just continue the auto support. Now, once intubated, of course, this is the time when you can actually say that this patient has ARDS. In fact, the ARDS of this patient, once intubated, it is already severe ARDS. Yung nasa initial start pa lang po ng critical na COVID-19, patients is basically already on ARDS. The mere fact that we are already giving them non-invasive ventilation, patients is already in ARDS. It is just at a lower level. So probably mild lang na ARDS. And that is why the auto support, the respiratory support that they need is just, in terms of non-invasive. But for those who are intubated, these are already patients who are already in severe ARDS. And once severe ARDS, then very important, you really need to have a pulmo on board, no? And also, if the patient is in the intensive care unit, bukod doon sa pulmo, you probably have to you probably also need critical care referral, no? But definitely a pulmo should always be on board, because the ones that are very knowledgeable about mechanical vent will be the pulmonologists. Ano pa ba yung nasa ano? And then, of course, reassess, no? Reassess once you are able, the patient is already intubated. So, assessment, monitoring will have to continue, no? And this has to be done very closely. And therefore, definitely, these are patients who are already in the ICU. Next. Okay, now we have to remember that once patients develop ARDS, no, they are the patients who would most likely be candidates to also develop sepsis. So if there is any deterioration, no, in the sensorium of the patient, or suddenly patient's hemodynamic drops down, then you need to always consider the possibility of sepsis. Okay, so how do you score now? You look at the SOFA score, no? We have actually the ones that you are seeing is the quick SOFA variables, no, which would take into consideration the respiratory rate, no, of more than 22, presence of an altermentation, and asystolic blood pressure less than 100 millimeters mercury. If you have this is a quick SOFA score. If you have all of this, then you have to consider the possibility of sepsis. Kung hindi naman po, no, pag sepsis, of course, you have now to do your standard of care for sepsis. Definitely, the standard of care for sepsis, ako ho, pag nagsisepsis na yung pasyente, hindi ho ninyo makikita yan dito. But for me, personally, I'd rather that I have the IDS on board, no? It's very difficult to manage sepsis, particularly in a hospital setting. So I always have an IDS on board. Definitely, these are patients who will have to be managed in the ICU, and you have to give the appropriate antimicrobials within 1 hour. We have guidelines, no, that we can actually use in giving the antimicrobials. And then, of course, blood cultures will have to be requested, no? And then part of the standard of care is effective fluid resuscitation. Now, I'd like to probably say something more about fluid resuscitation, particularly in patients who are also in ARDS, no? So patients in ARDS, the usual ARDS that we see, not the ones in COVID, no? Yung dati natin nakikita na ARDS. Usually, we don't read our main management as far as fluid resuscitation is concerned is really to make the lungs as dry as possible. And therefore, masyado ho kaming matipid pagdating sa fluid management, no, among patients with ARDS. But in COVID-19, this is not actually what we are usually doing. It is more detrimental to keep the lungs as dry as possible. So we really need to ensure that the patient gets the proper and adequate fluid management, no? Now, especially if they are in sepsis. the more that they need to have the effective fluid resuscitation that they need. Administer at least 30 ml per kilo per hour, and then you monitor the for volume overload. So you need to make sure that you monitor this. Actually, you can what we usually do is we really have to do our chest x-ray, because by doing the chest x-ray you'll be able to see if there is progression of the pulmonary congestion or the pulmonary edema. And for those who are hypotensive, then we have to apply vasopressors. So for vasopressors, the main vasopressor that is being recommended is norepinephrine. Next in line is vasopressin. So these are because what we want to do is really more to achieve vasoconstriction, no? So because the problem with sepsis is that they are vasodilated. And if the patient has any form of cardiac dysfunction, then maybe these patients would also would also benefit from the use of dobutamine, but usually we give them only low dose dobutamine so that we will be able to improve the contractility, because anything higher, at higher dose, then what we see is already more of an arrhythmogenic effect, for dobutamine. So, and then of course, if you have standard for sepsis, you will also have to consider referral to an intensive care specialist, and then reassess, So return to the previous algorithm, of management of moderate to severe sepsis. Now, paano naman kung ang SOFI score mo does not seem likely to be sepsis? So wala, okay ang wala yung altered mentation, cannot be respiratory rate greater than 22 kasi lahat yan greater than 22, But altered mentation, systolic BP less than wala yan, Kung maganda, then you need to do your SIRS, your systemic inflammatory response syndrome scoring. And if the SIRS score is equal to or greater than 2, then these are patients who also would also have SIRS. So SIRS is actually the beginning of sepsis, and therefore you will still need to apply the standard of care for sepsis and refer to intensive specialists. Now, if the SIRS is not less than 2, then sepsis is basically unlikely, and therefore you are able to rule out sepsis, and you go back to the old algorithm that we have. Okay, it's an algorithm for the management of severe sepsis. I hope that I am able to enlighten each one. Again, I'd like to thank PISMID for inviting me, especially our current president, Dr. Ika Alejandria. Thank you, Dingyong. Back to you.
Thank you, Dr. Limpin. So we are receiving a lot of questions already in the chat box or a Q&A box. So for those who have questions, please don't hesitate to type them in the Q&A box down below. And then we will answer them in the open forum. If you notice, some of the speakers have been already answering the questions for you, and we will be discussing them in the open forum. So at this point, after discussing patients who are hospitalized for COVID-19, now let's move to patients who are under palliative or hospice care. So to discuss, I'd like to call on the president of the Philippine Society of Hospice and Palliative Medicine. She is a family medicine practitioner, Dr. Karin Garcia.
Okay, thank you. Thank you, Dr. Biruar. And good morning to all. First of all, I would like to thank PISMID for the invitation here in your virtual and annual convention. And of course, I would also like to thank HPAAC for opening this partnership with the Philippine Society of Hospice and Palliative Medicine to be one of the contributors in the development of the COVID-19 unified algorithm. So my part will be on special considerations, in particular advanced care planning and end-of-life symptom management for irreversible respiratory failure in COVID-19. COVID-19 patients. So algorithm 4A, just to give context to this, is about advanced care planning. So in a confirmed COVID-19 patient, or whether they are suspect, probable case, discussions or thoughts about advanced care planning actually is an essential part in the patient's management. And thus, three important questions will come in, no? Always arise. Why do we need it? How do we do it? It's specifically in this COVID situation, and when. Okay, just to put context to it, no. So, if you're diagnosed, the why, no. If you're diagnosed with something that is life-threatening, and in this particular situation, COVID-19, okay, whether it be mild, suspect, or probable, or if you are even, in a moderate or a severe case, okay, because of that fear of uncertainty, okay, and that your desire to achieve your values, your goals of care, your preferences, perhaps ito yung mga most significant reasons for discussing advanced care planning. And when you talk about advanced care planning, it's actually your medical directives with your values, with your preferences, okay, including the decision to have a surrogate decision maker. So how do we do it? It's highlighted there. It has to be always continuous. It's a continuous process, and it will depend on the patient's current condition and prognosis. So yung assessment is important for decision making, discussion on medical dilemmas, and treatment options. So when we talk about treatment options, these are yung mga life-sustaining treatment, and I think the previous speaker also elaborated on the use of mechanical ventilator, okay, vasopressors, okay, all of this, part of the algorithm. And when do we actually need to discuss it? Okay, so it has to be appropriately timed. And yung sasabihin nga, may proper timing ba kasi hindi din, uncertain yung situation. But we are guided by several factors. Okay? Tinitignan natin yung status most important, yung prognosis, okay? Including yung patient and yung and the family's values and preferences. And sana yung kakayahan or the healthcare workers team or facility capabilities. Okay, next slide po, sir. Ayan. Okay, so focusing on advanced care planning. So if you have, a confirmed, probable, or suspect COVID-19 patients, okay, and the decision to discuss advanced care plan will set in, okay, and the first question that we need to solve here is the mental capacity. Is the patient capable of deciding for himself? Okay? So ano po ba yung criteria? Halimbawa, he or she is not capable, then that substitute or the surrogate decision maker will be needed. And saan po natin yan binibase? So if there is a power or a durable power of attorney, that overpasses everything. But usually, of course, the next is your spouse, okay, the parent or the child, and then the siblings and other relatives appointed by the patient, okay? And for in case, let's go down, in case that there are no appointed surrogate decision makers in some families who have difficult dynamics as well, then the medical team will come in to become the decision maker. Okay, so the medical team will always have to work in the best interest of the patient. So baka may mga previous na discussions or values that were informed to each of the family member, we need to include those. So if you are in that situation, sa tingin natin, kung ganito ang sitwasyon, what would he or she would want, no? So yun po yung mga questions that we need to go. And then, if there is a surrogate decision maker available, Then patient and family and physician discussions will come in. Okay, so this one is important. This is actually the skill. Okay, plus yung discussions, the model that we use, okay, is, a shared decision making. So when we're looking at the skill, we're looking also into what are those guides? Paano ba tayo guided when we talk to families, okay? When we talk to patients, okay? So of course the setting should be right, okay? We have to ensure comfort. You assess the emotional temperature of yung gravidity noong situation, and even through tele, no? Kasi we're called in sometimes to be the liaison for the family. Nakikita din natin yon, nararamdaman natin sana yon. And then we listen, no, to patient concerns. So this is actually perception checking, okay? And reassurance, patient and the family's concerns. And then we give the information that is needed, okay? Assess the need, what is their understanding, then we give the information, we deliver it. Of course, the key word here is always empathic, okay? Empathic delivery. Then the last will be actually to explore those emotions, okay? And then, provide that support. Okay, so, and once an advanced care plan has been set, then we have to document it. And this is what we call now your advanced medical directives. So advanced medical directives can be varied. Okay, it can be different in different institutions, even abroad they have one. But, two things that we can summarize here are the life-sustaining, and the second one will be comfort measures. It has to be included when we discuss advanced care plan. What if the situation becomes irreversible? Then, ang pinag-uusapan na po natin dyan is comfort measures, end of life. Then, we review, no? We review the goals of care, especially along the course of the patient's confinement and illness. So I think that's for advanced care planning for algorithm 4A. Now for algorithm 4B, this is wherein end of life symptoms, okay? For if the situation becomes irreversible already and there is irreversible respiratory failure, so we have a critical confirmed COVID-19. There are actually, because of yung end, how we look at it at the end for these patients, there will always be that dyspnea, okay, that the most distressing will be that dyspnea, as well as later on the agitations or delirium that might set in, okay? So when we're looking at dyspnea, so yun na nga po, no, is it more than respiratory rate is more than 30, then we consider starting opioids. Of course, this is with the direction of your advanced medical directives, the discussions. And when we look at opioids, okay, it has been there for centuries to treat respiratory, for the dyspnea during end of life, that shortness of breath. It works two ways, okay, but in generality, it helps remove that subjective sensation of dyspnea and that anxiety. So if your patient, medyo may relief ba, or let's say no relief, then we can start already opioid infusions. Actually, in the next slide po, sir, there are a list of opioids, options, that whatever is available in your institution that we can administer. So the key here is a regular monitoring, okay? And in case, going back to that algorithm, if there is no relief, then we have to start our infusion, okay? If there is relief, then we continue our opioid protocol. What do we mean about relief? So when we talk about at least sana ang respiratory rate less than 20, comfortable looking yung patients, and that there's no, yung parang, hirap yung that look of air hunger, then that is okay with the family members and of course the medical team, then we continue. Let's say, there are additional distressing symptoms such as agitation or delirium, okay, which can also occur and it can be very distressing. Then we have to consider starting, of course, your haloperidol or your midazolam. Okay, so ano po itong ano natin? So we start it, okay, actually, nasa next slide po natin yon. When we start, okay, your okay, sige po, balik na lang po sa algorithm. So our midazolam and haloperidol, including if there is relief, okay, with 3 doses of your midazolam, let's say, in the 24-hour, then we continue that current dose. But in case that there is no relief, okay, medyo hindi talaga maganda yung situation niya, then we start what we call our palliative sedation. So, I think may slide po ito, but I don't know if napasok po, no? But when we discuss palliative sedation, okay, it is actually a measure of last resort, okay, and that it we use at end of life care there, no? Okay po. Thank you. And that we use at end of life to relieve severe and refractory symptoms. The key word here is what we call intolerable suffering. Mahirap siyang i-define, and that's why it's important to have early on advanced healthcare discussions, advanced goals of care discussions, because each one can actually have different, aside from your objective measures of distress, okay? So we have to really bear in mind the preservation of the patient's moral sensibilities, medical professions involved in the care, and the concern of family and friends. So continuous ang communication natin with them, okay? And that's the dose when we start our palliative sedation. It's a midazolam infusion, okay? And earlier, as what I've said, if there is an immediate, we need to, remove that agitation or delirium or to control it, then these are the recommended medications. Your haloperidol is there, your benzodiazepines, midazolam, diazepam, going down to chlorpromazine, okay, at different dose and dosing intervals, okay? So I think after this, okay, so yeah, treat other symptoms. So what are those symptoms that can also manifest in the end of life, okay? So sometimes yung what we call that increased in that secretion, no? Kasi medyo nag-gurgling sound, at what we call that death rattle, no? So we usually start our patients with your hyoscine butyl bromide at least every 8 hours. We also look if, kung meron bang mga cough na mag-evolve, vomiting through NGPs, yung madaming residuals, then we do treat the symptom, okay? And in the course of the patient's illness, and you have controlled the most distressing symptoms, and the patient now is actually in the actively dying situation. So what are the signs that will tell us that your patient is actively dying? So meron naman tayo mga objective, but of course that long pauses in breathing, you have your slowly decreasing blood pressure, at least there's a steady state decline of more than 20 millimeters of mercury, skin color changes, okay, the state, semi-coma, coma, okay, urinary and bowel incontinence, hallucinations, and of course, you mentioned build up already of the fluids. And if when it's in this stage, then we maximize all comfort measures. It's a very broad term, but when we talk about comfort measures, it's actually yung going to the dying process, okay, and let it occur. Let's let it occur. But the focus now here is the psychosocial support that we give our family members, and including yung spiritual interventions if warranted. Okay. And I think the last there would be bereavement. If the patient succumbs, then bereavement care will set in. And when we talk about bereavement care, iba-iba din po in different institutions, but some would actually even, sending condolences, making our lines open to family members for questions can actually be of big help, especially during this grieving period. Okay, so I think I'm done, Dr. Dance. Thank you very much for clicking my slides. And ayan. Is there any?
Okay,
Okay,
thank
thank
you.
you.
Thank you, Dr. Karin Garcia. So it's already 11 o'clock and our session will end at 12 noon. So at this point, now that we know how to contact trace and then manage our patients in and out of the hospital and then manage palliative care patients, now we need to know naman no, how to integrate patients who have been diagnosed with COVID. How can they go back to work? This is a very important issue that I think everyone has faced whenever we have patients who have COVID. Kailan ba natin sila pwedeng pabalikin sa kanilang workplace? So I'd like to call the National Secretary of the Philippine College of Occupational Medicine and who is also a medical director of the Perpetual Health Medical Center in Binyan, Dr. Ria Fajardo.
Thank you, Doc Ding Dong. A pleasant morning to our guests, delegates, speakers, officers, and organizers of the 42nd PISMID Annual Convention. The Philippine College of Occupational Medicine, PICOM, would like to thank the Philippine Society for Microbiology and Infectious Diseases, PISMID, and the Healthcare Professionals Alliance Against COVID-19, HPAAC, for this opportunity to share our advocacy for the health and safety of the Filipino workforce. And we are sincerely grateful, Sir Tony Dance, Ma'am Isa, for giving us this opportunity to ensure the health and safety of the Filipinos as we battle COVID-19. So may I have the first slide, please? I will be talking about first this algorithm on discharge of patients with probable or confirmed COVID-19 criteria for discontinuation of transmission precaution. Now, for those who are part of the occupational health team or of any workplace, or for those attending physicians of our workers requesting for medical and work clearance, the next two algorithms will provide some clarification or structure for your decision making. So with this first algorithm, figure 5A, we come from the contact management algorithm, the asymptomatic patient algorithm, the mild and moderate patients, and management of pneumonia algorithms. Okay, so we start with whether they are probable or confirmed patients, classified into severe or critical, and mild or moderate. Okay. So what if they are severe or critical, or were severe or critical? So has it been 21 days since onset? And for those with mild or moderate, has it been 10 to 14 days since onset? If not, then we must defer discharge until the criteria has been satisfied. Okay. So next, if they do meet this criteria, that for severe or critical patients, 21 days has passed. For mild or moderate, 10 to 14 days has passed. Have they improved for at least 3 days or more? So for our clinical improvement criteria, we have our footnotes to guide us as well. And in the footnotes, it says that the patients must have at least no fever or use of antipyretics for at least 3 days, that their respiratory symptoms have reduced significantly, and if the chest x-ray is available, must show significant improvement or clearance of the previous consolidations or signs of pneumonia. Okay, so if they have improved, or if they have not yet improved, defer discharge. Okay, but if they have improved, and the next question is, are they immunocompetent? All right. So we again have a criteria for our immunocompetent patients. These immunocompetent patients, in the footnotes, it says they are not immunocompetent patients are not on chemotherapy for cancer. They do not have untreated HIV infection. They do not have combined immunodeficiency disorders, and they are not currently taking prednisone for the past 14 days. Okay? So if they do not meet this criteria, meaning if they are immunocompromised, then they must repeat the RT-PCR, okay? And if positive, refer to the infectious disease specialist and defer discharge. But if their RT-PCR is not positive, meaning it is negative, then they may be discharged. Okay. All right. So I think, and some other reminders for our repeating of the RT-PCR for Sir Tony, I think there's a footnote there for repeating. So a repeat negative RT-PCR test is no longer needed for discharge of immunocompetent patients, okay, with suspect, probable, or confirmed COVID-19, regardless of the severity. All right. And of course, we remind these patients that upon discharge, and as they, of course, are managed at home, okay, they should have close follow-up. Again, close follow-up is still recommended, all right? And that his or her place of residence should be able to provide the necessary, what the HPAAC has always been requiring, the apat dapat, okay? And of course, to always continue to wear the mask, practice physical distancing, of etiquette, hand washing, etc. Okay, so I think we can proceed to the next slide. All right, for figure 5B, for clearing non-healthcare workers for return to work. Okay, so this is again coming from the previous algorithm, 5A, also coming from 1C, contact management, and from 2A, asymptomatic patients. So, of course, for our occupational health physicians, company physicians, or our attending physicians who are clearing or providing clearance for our workers, so you must ask the questions. Are these patients recovered from past COVID-19? Okay. If they have recovered or met the criteria for recovery, then yes, they may be given a work clearance. Okay. All right. Sir Tony, can we go back to the slide? Okay, thank you. And then if they have not yet recovered from a past COVID-19 condition, do they still have symptoms in the past 14 days? So if yes, they still currently have symptoms, then they proceed to figure 1A, which is the triage of patients during the COVID-19 pandemic. Okay? But if not, again, do they have exposure in the past 14 days? So we then proceed to figure 1C, which is for contact management, as explained earlier by Dr. Aileen Espina. Okay? And if not, do they have a positive RT-PCR in the past 14 days? So meaning, again, when someone in this criteria, you ask, so wala silang symptoms, so hindi sila COVID patient, but they do have an RT-PCR that is positive, then they must proceed to figure 2A for the community-based management of asymptomatic individuals with confirmed COVID-19. So if they are clear with all of these criteria, then work clearance can be given. But again, with guidelines on what our company physicians, OH physicians should be requiring from the different workers returning to work. Again, just some additional guidelines that hopefully request for the necessary documentation if they came from the temporary treatment management facilities or the different hospitals. Please request for the necessary documentation of this before giving a work clearance. So for additional guidelines, again, our footnotes are reminding us that the RT-PCR tests are not recommended for work clearance. Okay, the rapid antibody tests are not recommended for work clearance. Again, the rapid antigen tests are also currently not yet recommended for work clearance. But I think PISMID already gave also their recommendations for the use of these different kinds of tests. And when we need further clarification, we can also look to the DOLE DTI Joint Memorandum Circular 20-04-A released last August 15, 2020, and the DOH Workplace Handbook as of September 30, 2020 for further guidance. So I hope that with these two algorithms, we remember that once we discharge these patients or once we provide clearance for these patients, let us also think about their mental health, no, and their psychosocial support that they need when they are reintegrated back to the workplace. Because a lot of times these patients do feel that they are being stigmatized, no? They feel that there is some kind of maybe, you know, may mga chismis na umiikot or something. Syempre gusto natin i-welcome back yung ating mga workers sa workplace. Gusto natin silang to feel at home and to feel that their workplace family was praying for them, caring for them, looking after them even while they were gone. So again, let us think of the cultural, spiritual, and values of our workers as they are reintegrated back to the workplace. Okay? I think that's all for me. Thank you very much, Sir Tony, and to the team. Thank you.
So thank you, Dr. Ria. Please stay on. We have an open forum after the last speaker this morning. So for our last speaker, last but not the least, I'm going to call the president of the Philippine College of Emergency Medicine. She's going to be talking about the management of patients in the emergency care setting. So I'd like to call Dr. Pauline Convocar.
Thank you very much, Dr. Dingdong. And on behalf of the Philippine College of Emergency Medicine, I'd also like to congratulate PISMID for a very successful conference. And thank you as well to PISMID and HPAAC for the opportunity to also contribute to the unified COVID-19 algorithms. So I just would like to state before starting off with my very short section, is in the importance of the spectrum of care, because we know that care should not really be cut. It should be seamless from the first point of contact, and our desired state really is that we may be able to already take care of our patients even at the first scene or the first site of where the emergency happened, and in transit and until arrival to the definitive care. So that's really our desire. So this is where we are coming from, that perspective of providing for care that is continuous in a continuum, but still quality, and looking at the emergency services as a moving emergency unit capable of providing care even while in transit. So Sir Tony, my clicker, thank you very much. Next slide, please. So firstly, I'll be presenting a different scenario this time. So Dr. Maricar presented to you the in-hospital cardiac arrest algorithm, but this time this is the management of out-of-hospital cardiac arrest algorithm during the pandemic. So we've taken these 5 C's of care of the flow from a collaborative effort among the Department of Health, the Philippine Red Cross, the Philippine Heart Association in the expanded Council for CPR, and we've developed the 5 Cs of out-of-hospital cardiac arrest care during the pandemic. So what's just different here in our usual BLS or basic life support with CPR is that we have to remember the 5 Cs. Easy to remember. The first C is to check first if you're safe. It's our dictum, it's our mantra that we don't want to be the second victim. So when a responder or even a lay person attempts to save another person's life, we have to check first if the environment is safe, and that if the person who will attempt to respond is safe. If the person is a healthcare provider, of course, we have to understand if there is an appropriate PPE. So we need to check figure 6A and 7B for the appropriateness of the PPE. The second check is also to check first. Before, it used to be look, listen, and feel for movement and signs of breathing. But this time, since this is COVID, if you do not have your proper PPE on, you just have to look for signs of movement and breathing for that patient. So there are only two questions in an arrest, in an out-of-hospital cardiac arrest situation. You have to look for signs of unconsciousness or unresponsiveness and signs of no normal breathing. So even if there are signs of breathing, but this is not normal, the patient is gasping, therefore, Sir Tony, going back to the algorithm, therefore, we already need to call for help. Call for help is the second C, because the second C is calling for an AED, an automated external defibrillator, and activating EMS. The perspective of this algorithm 7A is on the perspective of a healthcare provider being, somebody on another end is calling for help if there is an instituted emergency medical response in your locality. So if there's no EMS that's already instituted in your locality, what may happen is that on the other end of the line may be a healthcare provider giving instructions. So this is where this algorithm is coming from. You as a healthcare provider should be able to tell the caller on the other end to bring the phone and attend to the arrested patient. So this superscript D, footnote D, is what you're going to advise the caller. But if you're already the bystander, if you're already the healthcare provider responding, then you'll probably already know what to do when an arrest happens. You're calling for help to activate the emergency response so that the ambulance will fetch the patient, or the more advanced emergency medical system team will be able to bring the patient to a more definitive facility. So that's the first call. And then don't forget, the fourth C is make sure that you cover the patient's or the victim's face with a barrier or a cloth barrier, or most of the time, most of the people right now are actually already wearing masks. So more likely the patient may be wearing a mask, but if not, make sure that you put on the mask or an appropriate barrier before performing anything. So we do not advocate mouth to mouth anymore, but in the event it is stated in the new guidelines that if this is a family member, more likely you have the same exposure anyway, so it's still okay to do your compression. So that's the fourth C, while waiting for the EMS to arrive. So once the EMS is now on scene, it's now next to the next slide, you'll now be able to now endorse to the EMS team. And or if the AED arrived first before the EMS team, because there may be other localities that have public access defibrillator programs. So like they just get the AED even if this is a bystander and connect, and that's the last C. So here, what's particular here is that we need to understand that in some EMSs, so may mga medical directions na kasi na in place that once there is return of spontaneous circulation. Next slide, Sir Tony, please. So after CPR, we're doing the CPR currently. So next slide. We need to ask if there is a medical oversight available. So what we're just saying here is that if there is a established EMS protocol in your locality, and the EMS team is there on site, if there is medical oversight, if there is no medical oversight, we need to transport the patient to the nearest capable center, because again, the principle is that we need to bring the patient to the nearest and the most appropriate or the nearest capable facility to probably continue the care, to continue the resuscitation, and or to declare if the patient is dead or was not successfully revived or post-mortem care. So if there's no medical oversight and there's return of spontaneous circulation, Sir Tony, next slide please. There's return of spontaneous circulation still to be brought to the nearest capable center. But if you have medical oversight and it's part of your protocol that you may declare on scene, the patient may now be brought, may not necessarily be brought to the nearest hospital, but may be declared dead on site, and just follow the protocols of your local localities for your municipal health officers to declare the death as out of hospital cardiac arrest. So that's for the section on, for the part of the out of hospital cardiac arrest. Moving on to the care in transit. So what you'll be seeing in the next two figures are just procedural. So this is different from the medical care in transit, wherein we have to address all the ABCDs of life. It's totally in a different algorithm, that's 7B, and even the infection prevention control of your conducting vehicle, which is 7E. So that will be not part of the scope of this presentation. So I'll just be limiting ourselves to 7B for primary transport and 7C, which is secondary transport. I'm saying primary transport, but the more globally accepted term really for primary transport is pre-hospital transport. But primary transport is just any kind of transport from the scene of the emergency to the first facility. So it may not even be a hospital. So that is why we prefer to use the primary transport here as a term of reference. So from all the figures, from patient navigation, the triage of patient in 1A, the management of out-of-hospital cardiac arrest during pandemics. If the patient is needed for definitive care, definitely for a primary transport, we all need to bring our patients to a facility. So here, the patient for transport to a healthcare facility is the starting point, but we need to ask ourselves if the patient is stable on scene or not, because that will really determine if medical oversight is needed or not as well. So next slide, sir. We have to just make sure that if there is a medical oversight available, we call for medical direction, because we need to also make sure that medical attendance is available if there are medical protocols in place, like say for chest pain, for trauma, and for other conditions that may warrant really medical care. And the team needs supervision from a medical director. But if it is not available, downward, sir. Okay, so and then continue with the receiving facility, communicating with the receiving facility. But if it is not available, or if the patient is not stable, we really need to bring our patient immediately to the receiving facility with or without the medical oversight. And we need to coordinate still if already established, say, because right now there are already regionalization and localization of command centers for COVID. So we need to coordinate with the direct institution that's a referral center for COVID, if it's COVID or for a suspect, or if not, then we should also consider following the protocol of the local government units. So the transport of patient in a COVID-ready ambulance is imperative if the patient is a suspect, a confirmed, or a probable case of COVID. And we need to look at 7D now for the management, the clinical management while in transit, because as what I've said, we should not manage our patients in silos, but we have to consider really the holistic approach of our patients from the site to the facility. Now, once your patient arrives at a facility, so that's for primary transport, and we now move to the 7C, which is interfacility transport or the secondary transport. Several scenarios may be happening all at once in your interfacility transport once you've coordinated. So one, you may have brought your patient to a facility that is capable really of addressing your patient's need. And so therefore, here, is the patient's condition safe for transport? Because you need to ask first if your facility is capable. But if your facility is not capable or does not have the facility competencies of the staff to address the needs of your patient, we need to prepare the patient for transport. So we start the algorithm with that question on if the patient is safe for transport. If the patient is safe for transport, again, we coordinate with the receiving institution or through the LGU command center, the One Hospital command center, if in Manila, here in the metro. But in other localities, you have to coordinate with your local government unit command center. If the patient is not safe for transport, consider, of course, stabilizing the patient first. You continue your management, and the course, kindly zoom, sir, on number 3. Just magnify.
Zoom's
Because-
not working anymore. Sorry.
All right, it's okay. So maybe 200/20 visual acuity of our participants. But the box number 3, if you'll also access in the PISMED website, just states there that we need to continue management, of course, until the patient is stable. And then coordinate still, because you know that you're not capable of handling the case. So you need to coordinate with the receiving facility. So just in a summary, what interfacility transfer here refers to, or it's focusing on, is the ability of your facility to address the need, and then also really to coordinate with the receiving facility through a platform or through a unit, which may be a one hospital command in one area, or whatever it is that you call as a command center in another area, since we do not have similar structures, but these are just guides. So just for procedural, of course, we need to understand that you have to have competent EMS team that will sabay dun sa ambulansya, hindi pwedeng sasakyan lang yan na tumatakbo, because again, kailangan may may nagmamanage ng kaso habang tumatakbo yung sasakyan, looking at the perspective of a vehicle as a moving emergency unit capable really of saving a life even in transit. So I think that's the answer, Tony, for me. The end point here is that the patient is well received in the receiving facility, and we now again enter into algorithm 7D, which is continuation now of management of suspect, probable, or confirmed COVID case po. So thank you very much once again, and it's really an honor, and nakakataba po talaga ng pusong nakasama ko po kayo sa paggawa po ng algorithm na to, kahit na puyatan. Maraming salamat po, and Merry Christmas everyone. Thank you, Sir Tony. Back to you, Dr. Ding Dong.
Okay, thank you, Pauline. Maraming salamat po sa lahat ng ating panelists. So at this point, I'd like to request the organizer to please post na all the cameras of the panelists so we can answer the questions. We actually have answered already 2/3 of the questions here in the Q&A box. And I'd also would like to invite the president of PISMED, Dr. Marisa Alejandria, and also from PISMED, Dr. Lara Saibel-Abad, who will answer some questions for us as well. So for the first question, I'd like to ask Dr. Abad to answer this one. Thank you for this. I just observed that the PPE algorithm is still based on earlier guidelines and not on the updated recommendations of CDC, WHO, and DOH, like the use of single gloves instead of double gloves, not using head covers and shoe covers. So will that be updated as well, or is this the recommendation of the group that we should use locally?
Thank you very much for inviting me, and thank you for that question. We will update the current guidelines, and it's good that the people recognize that these are kind of old recommendations during the beginning of the pandemic. So we will be updating those guidelines soon, and we will put the premium or the emphasis on really wearing the N95 and the mask/face shield rather than emphasizing the shoe covers and the headgear, which, as mentioned, is not part of the updated guidelines from the CDC and from the WHO.
Thank you, Dr. Abad. There's a question here for HPAC, and also maybe our colleagues from PISMID can answer as well. So I'd like Dr. Tony to answer this question. What is the reaction of HPAC on the recommended use of rapid antigen test issued by the DOH, but Department of Tourism requires the same for staycationers? And then, if you have a positive rapid antigen test, do you need to validate it with an RT-PCR test?
Yeah. Okay. Thank you for that question. Very controversial. I want to add siguro, Ding Dong, that things are changing so much. No, Lei showed the slide. Na we now have, I think, 170,000 articles on COVID, published studies since January 2020. About our last estimate was, initially it was one article every 5 minutes, and now it's, about a month ago, it became one article every 2 minutes. No, so that was our last estimate, and so the algorithm really needs to change, and that's why we prefer when people view the algorithms on the website, kasi that will be constantly updated. Napakita nga ni Pauline kanina, as of today, meron na kaagad updates. No? So this is really continuing work. With the antigen tests, ang nakalagay sa ating guidelines, we do not recommend it, di ba? And for me, there are so many opinions on these tests. For me, the last opinion should come from how the law dictated that these policies be made, and that be through the Health Technology Assessment Council, which is doing a continuing review on it, no, on rapid antigen tests. And when their word is out, then until their word is out, the Department of Health and PhilHealth and any public facilities will find it difficult to pay for antigen tests or recommend them until the HTAC comes up with a final recommendation. As far as I know, as of last week, there was no final recommendation on this from HTAC. I wonder if ISA might have heard if there were, if they've come out with their report already.
Tony?
Yeah.
Yeah. For rapid antigen test?
Yeah, meron na ba ang yung HTAC? Have they come out with their full evaluation of it already?
No, there are no new updates yet as of this time with regards to the rapid antigen test. So it's still for those whom you highly suspect and you have limited access to PCR and you highly suspect them to be suspicious or suspect for COVID-19, then that is when it's recommended, or in outbreak setting where you need a faster turnaround of results. No? Yeah. And if it's still if it's negative and you're highly suspecting COVID-19, then you have to do RT-PCR.
So, thank you, Dr. Isa and Dr. Tony. So, yung gold standard po natin is still RT-PCR, but for an outbreak setting, then you can consider antigen testing. So, just to be updated po, no, please visit the PISMID website. If you look at the chat box, we posted there the link where you can access the unified algorithm. So, consider it po as a living document. So, maybe make it a habit daily to check it for updates. Para ho makita natin kung ano yung bago, no? More than what has been discussed. And actually, there's still more algorithms that have not been discussed during this session this morning. So at this point naman po, I'd like to ask Dr. Maricar Limpin. There's a question here in the chat box. Does propofol have a role in the treatment of intubated ICU patients?
Once intubated, we really have to put the patient on sedation. So there is a sedation protocol, which is actually being done by the anesthesiologist. But propofol is one of the medications that are being used when we sedate the patients. Actually, other than sedation, sometimes we also need to paralyze the patient. So in that way, then we can really rest the lungs, no, and properly ventilate the patient until the patient is able to recover again the lung function, and we will be able to remove him from the mechanical bed.
Thank you, Dr. Limpin. So I have two questions here that includes clearance for work and contact tracing. No? So maybe I'd like to ask Dr. Aileen Espina and Dr. Ria Fajardo to answer the question. So we had a question here from an anonymous attendee who asked, how about clearance for work for healthcare workers who tested negative for RT-PCR who are close contacts with positive healthcare workers? So medyo mahirap po kasi pag healthcare workers because you are continuously exposed to the virus, no? What is included only in the unified COVID-19 algorithms is for non-healthcare workers and only for healthcare workers who are positive.
Dr. Aileen, should I? I'll comment first. Okay, so for healthcare workers who are in frequent contact with COVID patients, like for example, our ER consultants are in frequent contact with possible COVID patients. For as long as they are wearing the proper or the appropriate PPEs, then they should be protected, meaning that they are actually some infectious disease specialists would say that they are not at risk or that they have low risk for as long as they are wearing the appropriate PPE. We would consider them as being exposed or having high risk exposure if they are attending to a possible COVID patient but they forgot to put on the appropriate PPE, meaning may biglang nag-toxic sa ER, biglang pinuntahan nila, nalimutan nilang mag-wear ng goggles, nag-intubate. Okay, so ganon. That is a high-risk exposure to a possible COVID patient. And so the question is, how are they cleared to return to work? I think the algorithm is there. Hindi lang po namin na-explain during this session, but it's somehow similar to the non-healthcare worker, wherein you also ask them if they have symptoms. You also ask them if they have, of course, aside from their exposure in the healthcare setting, exposures at home, exposures in the community, and ayun nga po, we provide a risk assessment also for these healthcare workers. I believe for as long as, again, the PPE is there and the other necessary hierarchy of controls are in place, like your engineering controls, your administrative controls are in place, then we lessen the risk to our healthcare workers. Okay? I hope I answered that question properly. Maybe Dr. Aileen has some additional comments.
Thank you, Dr. Ria. I think the question is relevant in terms of contact management in the healthcare setting, no? Kasi lahat naman po talaga ng healthcare workers, by the very nature of our profession, we are really exposed because we are in an environment na mataas po talaga yung viral load, sabihin na lang natin. The hospital is a natural petri dish, not just for COVID, but for a lot of other microorganisms, viruses, etc. So, ang una ko pong tanong, bakit po siya tinest? That healthcare worker who was tested, was it part of the routine screening that is, or surveillance screening na ginagawa ng ibang hospitals? Or was that healthcare worker identified as a close contact of a colleague? Meron po kaming ganyang kaso in the RHU, wherein magkasama po talaga sa kwarto yung dalawang healthcare worker, yung isa was confirmed positive and then the other one So my trainee who is an MHO was asking me if kailangan din bang what will she do with the other nurse who was living in the same dormitory as dun sa nag-test ng positive. So we tested. So since ano siya, close contact, we did a test on the other healthcare worker who turned out to be negative. So ang next na tanong po, may symptoms ba siya, no? So we did the symptom-based test. We monitored the healthcare worker, and then we assessed the risk of exposure and the vulnerability profile nung healthcare worker. So there is really no fix na dikahon on how you're going to manage a healthcare worker na may exposure to a patient or to a colleague na kasama niya sa ano. Because we really interact with each other, and it's not just in the patient care setting that the transmission can happen. Kasi in this particular case, hindi ho tayo clear how the exposure was to the other healthcare worker. Could it be that they shared a meal together? Could it be that they are roommates? So, yun po those nuances are very, very important in terms of contact tracing. So, that's why in contact tracing, napaka-importante po ng interview. The cognitive interview is very important because it will give us an idea on the exposure and the history. So, babalik po talaga tayo sa clinical history ng ating pasyente. Exposure must be established, symptoms must be investigated, and then we do the testing and we combine all three. So parang we validate po, no? We cross-check each other para alam po natin kung ano po yung tapang na approach natin for cases like this. Yun lang, sir. Thank you.
Thank you, Dr. Espina. This question is a bit complicated, no? So I'd like to ask Dr. Isa or Dr. Saibel to answer this question. A seaman tested PCR positive was placed into 14 days quarantine. And then retest was done, and still the seaman retested positive, but I guess he's asymptomatic, no? Then he was asked again to isolate for another 10 days. So when can he go home, and when is he allowed to go back to work since the company requires a negative test? So I think at this point kasi kailangan i-refer na natin sa IDS for clearance. So maybe yung question here is if a patient tested positive for PCR test, is there a way for this patient to be cleared to go back to work or return to work?
Siguro I'll answer first, and then Ma'am Isa can add on to my answer. This is actually a very common question that we see in the outpatient setting or in the telemed setting. No, frequently our patients are being asked to have repeat RT-PCR tests, no, despite now the shift from a test-based strategy to a symptom-based strategy. So again, because COVID-19 is an evolving disease, no, we've from asking people to have 2 consecutive negative RT-PCR tests, we have now shifted to a symptom-based strategy. And so to answer that question, if the patient is asymptomatic and has completed the 14-day required quarantine or isolation period rather, then there should be no more need for further testing for RT-PCR, because as you can see in this case and a lot of other cases, they tend to have viral shedding of what we presume is dead virus already for a long time. So we've had cases where they are RT-PCR positive for many, many weeks after their initial positive test. And really, it's terrible that they have to be re-quarantined or re-isolated again for 14 days more at a time. And so I think we should really start to shift towards symptom-based testing. So when we do get these patients in the clinic, in the outpatient setting, we do clear these patients to go back to work, writing a letter, citing the guidelines, no, both the PSMID guidelines and the CDC guidelines, saying that there's no need to retest these patients. Ma'am Isa, do you have anything to add?
I agree, no? We would like to emphasize again that there is really no need to retest, because as you've mentioned, and this really creates more problems on how to deal. And we've seen that the virus that's isolated is not really live virus anymore. So viral shedding does not equate to infectivity, and it has been shown in studies already, especially when it first came out in Korea that they talked about reinfection, but they found out that on culture these were negative, and those who were exposed to this asymptomatic but still shedding the virus did not get the infection as well. And then probably just to add, if in situations where that test has been repeated already, for us, ID specialists, what we do, the additional test that may be done is an antibody test, an ELISA or a CLIA antibody test to determine if the patient is already mounting an immune response to the infection. That's one scenario where we use an antibody test. Thank you.
Thank you. Now I'd like to ask this question to Dr. Dance. Sir, there's a question here asking about the usefulness of the face shield. The doctor here is saying that he was not able to find any literature regarding face shield. I think you know the answer, sir. So could you direct him?
Share. If I find it, I'll share it on the. But they don't see the chat box. No, there's actually a meta-analysis which assessed the use of face mask, face shield, and distancing. No, baka kaya niya hindi nahanap. The authors lumped the effect of goggles and face shields together. So yes, there is a meta-analysis on it showing around an 80% reduction in the risk of transmission from about 12 comparative cohort studies.
Mm-hmm.
Thank you, sir. There's a question here regarding the 14 days quarantine. The anonymous attendee asked, I have patients 14 days or more. I'm sorry. Why is it that in the Philippines, 14-day quarantine is required, while here in the US, exposed or healthcare workers who tested positive, only 10 days quarantine is required and people could already go back to work? So, siguro yung problem dito yung difference between the US and Philippine recommendation. Tayo 14 days, sila 10 days. So, are we seeing the possibility na baka bawasan din po yung local recommendation? Dr. Isa?
Ma'am Isa, if I may po, before you answer the question, I just would like to stress the difference between quarantine and isolation. It's stated here po na tested positive. So pag nag-positive sila, 10 days isolation lang po talaga. Pero kung quarantine po, these are people who are contacts. And the 14-day period of quarantine is because of the 14-day incubation period. So yun po ang difference. If you test positive, 10 days kang i-isolate, pero kung contact ka at i-observe ka for symptom development, 14 days po talaga siya. So, yun po yun po yung klaruhin lang natin. Magkaiba po ang isolation at quarantine. Ma'am Isa.
Yeah. So yung 10 days versus 14 days debate or issue, the question is if the patient is asymptomatic, tama, Ding Dong?
Opo.
10 days, okay. Kasi so maximum is 14 days for quarantine, because you're waiting for the symptoms to develop. While yung isolation is for patients who are already with symptoms, as mentioned by Aileen, and then if you test them, then our recommendation there is you can already clear the patient for discharge or remove from isolation by 10 days if they have been asymptomatic, or clinically improving for the past 3 days, at least without fever for 24 hours, and it's more 10 days from the onset of symptoms, 10 to 14 days. Actually, we put a range na nga, 10 to 14, If you're referring to, kasi there's a recent guideline from CDC wherein they relaxed it to 10 days. That if you are asymptomatic already and the test is negative, then you can be released from quarantine by actually even 7 days. They put it at 7 days, no? If you have access to testing. Okay. That is to balance yung economic side of it, no? So dito pumapasok na yung balancing the need to go back to work, no? And the risk of transmitting. We've seen in the spectrum, no, of COVID-19 and the course of illness and the duration of viral shedding. If you will get the symptoms, it's usually during the first week, no? So yung incubation period nga, the longest is up to 14, but the median can be anywhere between 7-10. And also when they did viral cultures at 8 days, or there is most likely the viral culture is already negative at that point. So that is where this 10 days is coming from, no? Kaya we will need to review the evidence closely, no? And how if we can apply in our setting. Kasi yun yung it's something to keep in mind, especially if there are issues on having to go back to work, or you're a critical part of the workforce and you need to go back and you're asymptomatic, your test is negative, you can cut short the quarantine. And if we can put the risk that it is very low risk, and the advice there is if you already cleared not to go back, you still wear the mask, do hand hygiene, monitor yourselves for development of symptoms. So that advice remains, no, even if you're released at 10 days. So I hope I've answered that. So we will be reviewing, as we've said, no, the evidence is really evolving. We get more and more data. So our confidence, no, on 10 days, 14 days is, I think we will be able to give more concise or precise recommendations as we review the evidence again.
Thank you, Ma'am Isa. It's already 12 noon. Are we going to get an extension? There's still a few questions in the chat box. So actually, I'd like to invite all attendees to please visit the PISMID website. Nandun po yung unified algorithms, and they will be updated as information become available. So paki-check na lang po regularly.
Can I just add also, no, that we are also updating the guidelines. So kasi magiging living CPG na rin. So so the algorithms and the actual guidelines will also be updated soon, because there has been really a lot of changes in just this past month, no, and this month as well, no? Marami tayong gagawing reviews.
Opo. Ma'am Isa, may question po dito. I hope we can answer this one kasi sa province po, we'd like to help them. What's the recommendation test, especially in our area that there's no RT-PCR sa Masbate daw po?
Okay. Do you have rapid antigen test? That's where in an area where there's no RT-PCR, then rapid antigen test can be used for diagnosis.
Okay, thank you, Ma'am Isa. So it's already 12 noon, but before we close, I'd like to ask Dr. Tony Dance to acknowledge the constructors of the algorithm and also to close the session.
I'll close it.
I can close.
I'll just acknowledge and then Isa can close.
Sorry. Okay.
Kasi just to acknowledge the organizations that help develop it, no? PISMID, PCP, Society of Public Health, General IM, Emergency Medicine, College of Emergency Medicine, the Society of Hospice and Palliative Medicine, the College of Occupational Medicine and Kalusugan ng Mag-ina, But special, I think there were many contributors who aren't here today. This was really a multi-sectoral, multidisciplinary effort that involved, you hear from our speakers today, di ba? May emergency medicine, palliative care, occupational medicine, public health, epidemiology, everyone was involved. These are the people who really literally worked until the early morning of many days trying to refine the algorithms, constructing them, throwing it back to the guideline developers. No? So Dr. Antonio Alberto, Faye Bermudez, Donna Capili, Sarah Ream, John Hega, Siti Salibi, Lara Castillo, Paulo Cerrado, Chiqui De Leon, Philin Salvador, Mian Silvestre, and Patsy, who's a fifth-year medical student in the College of Medicine. So thank you so much for these volunteer efforts for getting these algorithms done. And over to you, Isa.
Yeah, thank you. No? So before I close, I really have to thank everyone. No? Lubos na pasasalamat sa lahat. No? Tony, for initiating this, no, the algorithms, and then bringing in our friends, no, in the primary care and public health setting, Lei, Aileen, and then emergency medicine, Pauline, palliative care, Dr. Karin Garcia, and of course, PCP, no, Maricar, and Ding Dong, and of course Mario, our president now in PCP, no. You've really enriched your participation, the collaboration, no, has really enriched our guidelines, the algorithms. So we've covered all aspects, and this is what is really needed, no, in giving quality care for our patients. No, it's from primary care down to palliative care and end of life issues, and then putting in emergency medicine as well. So I'm very much grateful and very happy that we have collaborated and that we will continue to collaborate. Of course, thank you to our algorithm constructors, no, as mentioned by Tony, and they've all done volunteer work. No, it's all volunteer hard work, and it's really very, very much appreciated. So, thank you for enriching our convention, no, our anniversary with this session. Maraming salamat po.
Thank you to PISMID, Isa.
Yeah, sure.
Our heroes.
Maraming salamat. Because we were really, we needed all the help when we were attending to the patients. So, and it was really very, very timely, you know, with the rapid reviews and the algorithms that helped us guide, no, our healthcare practitioners in managing COVID. So do join us, no, in the succeeding sessions. I also invite you.
Kami mag-attend.
It's free. We'll post the link. You can attend our gala night also tomorrow, and then the closing ceremonies later as well. Plus the sessions, no?
Free Free naman, di ba?
Oo, free.
Free yun eh. Free. Actually, we can attend, Tony.
Yay!
Ano lang.
Mabuhay ang PISMID.
Thank you. Thank you, Isa. Thank you, PISMID.
Okay. Bye-bye, everyone.
Bye.
Stay safe.
Bye.
Thank you, PISMID. Thank you, Ma'am Isa.
Bye-bye.
Thank you, Ding Dong. Maraming salamat.